Hello everyone.
Today we are
Today we are
going to
going to
discuss
discuss
about the
about the
abnormal labor and
and
childbirth.
childbirth.
So it is
So
the
it is the
most
most
important
important
topics in the
topics in the
OBG2,
OBG2,
and in
and in
this
this
chapter we
chapter
have
we
the
have the
different
different
topics
topics
under
under
this
this
units.
units.
So what are
So what are
the
the
topics,
topics,
most
most
important
important
topics?
topics?
First we
First
will
we
see.
will see.
First one
First
is
one is
induction of
induction of
labor.
labor.
The
The
second one is
second one is
malpresentation.
malpresentation.
Under
Under
malpresentation we
malpresentation we
have
have pro,
face
face,
and
and
breech
breech
presentation and
presentation and
shoulder
shoulder
presentation.
presentation.
And
And
the
the
another
another
topic is
topic is
pelvic
pelvic
disproportion
disproportion
and
and
obstructed
obstructed
labor,
labor,
preterm
preterm
labor,
labor,
fetal
fetal
distress,
distress,
premature
premature
rupture of
rupture of
membrane,
membrane,
and
and
obstetrical
obstetrical
operations like
operations like
forceps
forceps
delivery,
delivery,
vacuum
vacuum
delivery,
delivery,
and
and
cesarean
cesarean
section.
section.
And
And
also
also
in this
in this
chapter is
chapter is
included with
included with
in
in
the
the
semester
semester
batch
batch
episiotomy,
episiotomy,
and
and
after
after
vaginal
vaginal
delivery,
delivery,
after
after
cesarean
cesarean
delivery, what
delivery,
is
what
the
is the
vaginal
vaginal
birth. So
birth.
all
So
these
all these
10
10
topics are
topics are
important in
important in
this
this
abnormal
abnormal
labor.
labor.
So first
So first
we
we
will
will
see
see
about the
about the
induction of
induction of
labor.
labor.
You know
You
what
know
is
what is
induction of
induction of
labor? So
labor? So
today
today
we are
we
going
are
to
going to
discuss
discuss
about
about
induction of
induction of
labor now,
labor now,
first
first
topic.
topic.
So the
So the
induction of
induction of
labor, the
labor, the
name
name
itself is
itself
there.
is there.
Induction means
Induction means
inducing the
inducing the
labor.
labor.
So inducing, when the woman is not getting the normal labor after her 37th week of pregnancy, or the pregnancy is continued till 42 weeks, okay, so that time, otherwise we will tell the silent uterus, when the woman is not, contraction is not started, so the silent uterus also we can induce. So induction means inducing the labor pain artificially, so that is known as induction of labor. So when it will happen, when the woman is not showing the sign of labor, true labor, and it's going, the labor, pregnancy is continuing the 42 weeks, that time we will be artificially, we are making the woman to get delivered, means we are stimulating the uterus to contract. So that is the induction of labor. So what is induction of labor? Just I will read here. So induction of labor, induction of labor is impulse the artificial incision of a silent uterus or uterine contraction in the silent uterus. So by any method, it may be the medical method, or it may be the surgical method, or it may be the combined method, we can do the induction of labor. So when it happen means it should happen when the uterus is not contracting by spontaneously, or the pregnancy is continued more than 42 weeks. So that time we are making the artificial uterine contraction. So that is known as uterine induction of labor. So what are the indication for this procedure? So the indications like maternal indications like diabetes mellitus, the mother who is having the diabetes mellitus, and hypertensive disorder, autoimmune disease, renal disease, and pre-labor spontaneous rupture of membranes. The rupture of membranes happen, and after that there is no active labor, okay, there is no uterine contractions, okay, so that time can have, then we can induce the labor. And also intrahepatic cholestatics of pregnancy, that is one of the condition, we can make it the induction of labor. And maternal request also, and antepartum hemorrhage, okay, the bleeding, okay, the mother is having the bleeding during her pregnancy, due to that also we can induce the labor. So this is the maternal complication. And what is maternal indication, and what is the fetal indications, like post maturity. I told the pregnancy is continued more than 42 weeks, or more than 40 weeks, 41 weeks, then we can induce the labor. Then intrauterine growth restriction, oligohydramnios. Oligohydramnios means it is a less amount of amniotic fluid, and polyhydramnios, excessive amniotic fluid in the uterine cavity, and RH isoimmunization, and corrected unstable lie, okay. So after corrected the unstable lie of the fetus, then we can induce the labor. So these are the some of the indications of induction of labor. And also, before going to induce the labor, we have to make sure that the pregnancy week, okay. So that is a very important. Gestational age must be confirmed before inducing the labor, okay. Before starting the procedure, we should confirm the pregnancy week, because this induction can be performed after 37th only. Okay, so that is the main things. And contraindication, why, what are the situation we should avoid this induction of labor means, there are some contraindications, like absolutely we have to avoid the conditions like a severe degree of contracted pelvis. Okay, the mother is not having the gynecoid pelvis. Okay, so it may be the android pelvis, okay, or polypeptide pelvis. If the mother is having, then we should not perform the induction of labor. Then major malpresentation like transverse lie, oblique lie, the fetus is there other than the longitudinal lie, then we should not perform, but after correction we can perform the induction of labor. Then presentations like Mendo posterior presentation is like one of the malpresentation we can tell. So when the fetus is there in the malpresentation, we should not perform the induction of labor. And also like a cord prolapse. Okay, then cervical cancer, classical cesarean section. The woman is underwent previously classical cesarean section, and we should not perform the induction of labor. The relatively contraindication. What are the condition where we can slightly we can avoid this procedure means, like non-reassuring the fetal status. We are not able to identify that the fetus is reached to the below cavity or not, means in the pelvic cavity or not. Okay, so when you are not assuring that the fetus is in the positive, that is +1 +2, or the fetal station is good, then we should not perform the induction. Severe cardiac disease, the woman is having cardiac disease, then you should not perform cervical fibroid, as well as the impacted ovarian cyst. Okay, so these are the conditions we should avoid the induction of labor. Okay, so next one is how to perform the induction of labor. Okay, so there are different method I told in the induction, introduced things only, that is medical method, surgical method, or combined method, or mechanical method. Okay, there are 4 methods are there. First, before starting the induction of labor, first things we should see that the mother is favorable for the induction. Okay, so how to identify the mother is favorable for this procedure? PSEP score. Okay, that is known as PSEP score. So we should identify the scoring method. We should assess the mother to before starting the induction, we should assess the condition of the cervix. Okay, cervix we have to assess. So that when it is become normal score, then we can start the induction of labor. Okay, so that scoring method is known as PSEP score. So this is the scoring method. Okay, so what are the things we'll be seeing in this scoring method means the dilatation of the cervix, and effacement and station, fetal station and position of the fetus, as well as the cervical consistency. Okay, so when all these things should be checked before starting the induction. Okay, so the favorable score, the total score is 13, the favorable score is above 6. When the mother is getting the above 6, then we can start the induction. If it is unfavorable score means 0 to 5. When the score is coming below 5 or 0 to 5, then we should not perform the induction of labor. Okay, so that is the main thing. So then what should be done if it is unfavorable? We have to make the cervical to reopening, then we have to start the induction. Okay, cervical reopening. So making cervix become soft, it is known as cervical reopening. Okay, so that is the thing. By using the prostaglandin, that is tinoprostan and misoprostan, we can apply in the cervical area, then we can start the procedure. So when we applying this prostaglandin, the cervix will become soft, then cervix will start dilate, then effacement will take place and fetal station will come to the normal, then we can start the induction of labor. Okay, so before, if it is unfavorable condition, we should start with the cervical reopening, then induction of labor. Okay, so that is the main thing you have to identify. If it is favorable, then we can start directly to the procedure, any method like a medical or the surgical methods. Okay, so here some of the methods I mentioned. Okay, so medical method, when we are talking about medical method, we are using prostaglandin and oxytocins. Okay, so that when we are administrating the prostaglandin, it may be in the form of gel or it may be in the form of IV also we can provide it. Okay, so oxytocin, oxytocin is the drug where we can make the uterine contraction. Okay, spontaneously or artificially we can make the uterine contraction. So we can administrate the oxytocin or prostaglandin, it is the medical method. The second one is surgical method. What is surgical method means? The swiping of membrane, okay, swiping of the membrane. So using two fingers on the obstetrics or the obstetrical or midwifery nurse, we can make the cervix, on the cervix in the clockwise, we can swipe it on the cervix. So that will stimulate the oxytocin naturally and the fetals in the amniotic sac, okay, then that will make the uterine contractions, okay. So that is a cervical reopening, we can tell, or artificial rupture of membranes. What is artificial rupture of membrane? Amniotomy, okay. So using the amniocook or artery forceps, okay, so that we can make the rupture in the amniotic sac. So when we are making the rupture in the amniotic sac, what will happen? The amniotic fluid leakage will be there, so that fetal cells are there, no, that will be stimulating the endometrium, that is decidual layers, to produce the oxytocin naturally, okay. So that is a surgical method. Cervical reopening or the artificial membranes, okay, amniotomy can perform. So even sometimes combined method means by applying the prostaglandin or administrating the oxytocin, we are performing the amniotomy. So that is the combined method. Otherwise, we can make sure that when the mother is unfavorable, we are using the prostaglandin, correct, to make the cervix become favorable. Then we are going to make the amniotomy to conduct the induction of labor. So that is also known as combined method of induction, okay. The next one is mechanical method. So when you are talking about mechanical method, you can see here mainly the mechanical dilator can be used, okay. It is an instrument where we are going to instruct in the amniotic sac and we are going to dilate the thing, cervix, okay. In the cervix we are going to introduce and we are going to make the dilatation of the cervix, okay. Otherwise we can use the Fal catheter. So that is making the rupture, again it's making the rupture when we are introducing the Fal catheter and we are making the rupture, no. So that is also one of the mechanical method of induction, okay. So this is the methods of induction, and next we are going to see about, one second, all these things I explained in the sentence. Okay, so observation is very important when you are performing the induction of labor, because assess the mother condition as well as the assess the fetal monitoring the fetal condition. Assessing the maternal what are the maternal assessment means? You have to assess the vital signs, okay. Pulse rate, respiration rate, and BP, we have to assess the mother. And the same time, we have to put the mother on the fetal monitor. Okay, fetal heart rate should be monitored. The normal fetal heart rate is 120 to 160 per minute. Okay, so that should be monitored, and you have to see that if it is performed the amniotomy, you should assess the amniotic fluid color. Okay, any blood stain is come or not. Okay, the flow, everything should be checked out. Okay, so this is the observation, we can make it out, and we want to see the timing also. Okay, should not more leads to the other time. Okay, so there are sometimes the failure of induction also can occur. So that time what should be done? Medical emergency cesarean section should be immediately started. So this is all about the induction of labor. Can you So, induction of labor, I think I would have explained clearly. So, induction of labor means it is the artificially inducing the labor. Okay, so that is known as induction of labor when the silent uterus is there. Otherwise, post maturity means after 42 weeks of pregnancy, still the mother is not getting the labor, then we can induce the labor by medical or surgical or combined method. Okay, by using the prostaglandin or by using the oxytocins with the help of aminotomy, it is a successful rate. Okay, so that is known as induction of labor. Next we are going to discuss about the obstetrical operations, that is forceps delivery. Okay, so forceps delivery is one of the abnormal labor. Okay, so what is forceps? So forceps means it is a special instruments made by in the obstetrical unit to get the delivery of the fetal head. Okay, so see here, this is the forceps. So it is a special instrument designed to assist the extraction of fetal head. Okay, so it is when we are when the labor is not effectively, especially the prolonged labor or obstructed labor is occur, during that time we can use the forceps to take out the delivery of the fetal head. Okay, so that is known as forceps delivery. So this is the forceps. So it have the different parts. Okay, so this is the handle and shung, and it is a blade. So the blade is having two curve, that is cephalic curve and pelvic curve. So pelvic curve, which is going to attach in the pelvic cavity, that is in the uterus, and the cephalic curve, which is going to attach into the fetal, means to cover the hold the fetal head. And also we have the lock. Okay, so that is one of the parts of forceps, obstetrical forceps. So you can see here the component of obstetrical forceps, which we have this side, which is known as this side is known as pelvic curve. Okay, so which we are going to induced in the cervical, in the cervix through the cervical os to the uterus. Okay, so that part is known as pelvic curve, and inside is known as cephalic curve, which is going to catch the fetal head. Okay, and this is known as shung, and this is the lock, and this is the handle. Okay, so this is the different parts of forceps. So types of forceps. So according to the situation, we have the different types of forceps. Okay, low forceps, mid forceps, and high forceps, and outlet forceps. So low forceps, when low forceps we can use means the baby head is visible at the mother's vagina opening without doing anything. Means example, the head is reached to the vaginal cavity. Okay, but it's not coming out again anymore. Okay, it's not taking the descent anymore. So that time we can use the low forceps. And mid forceps, what is mid forceps means the baby's head has ended in the mother's pelvis but is not visible at the vaginal opening. Okay, so mid means not on the vaginal opening, it may be above the vaginal opening. Okay, still it's not visible in the outside. Okay, so that time we can use the mid forceps. Then high forceps, when we can apply the high forceps, obstetrical forceps means application of this forceps when the baby head is just under the mother's pelvis. Okay, so means the fetal station is 0. Okay, means it is not like it enter into the below the brim but not up to the ischial spine. Okay, so not taken engagement, just enter into the below the brim, then we can use the high forceps. The next one is outlet forceps. So when we can use the outlet forceps means the baby head is under the pelvis, and the baby's strap means the head is appearance between the contraction. So each uterine contraction, the baby head is coming to the vaginal cavity and going back, vaginal cavity and going back. So that time we can use the outlet forceps. So these are the 4 types of obstetrical forceps. So indication for this obstetrical forceps. So what time and what are the times or when it can be introduced, when we can be use this obstetrical forceps means first one is maternal indications. The maternal indications like example maternal exhaustion means to cut short the second stage of labor. So when it is, I told when the obstructed labor is occur, that may leads to the prolonged labor. So during that time we can apply this forceps method to get the delivery. So that is a maternal extraction. Example, eclampsia condition, we can apply this forceps, and mother is having heart disease and severe anemia, okay, to cut short the second stage of labor. Okay, so second stage only the baby will get delivered. So to cut short the second stage duration, we can apply, and also applied to after coming head of the breech delivery. Okay, so after breech delivery, in the abnormal breech delivery is there. So once the breech is delivered, the head is inside the uterus, then we can apply the forceps to take out the head immediately. And prolonged second stage, when the second stage is taking longer time, that time we can apply the forceps. Okay, then fetal indication include fetal distress in the second stage. So when the fetus is in the distress, when we are identifying in the fetal monitoring, okay, then we can apply the forceps. So these are the indication. What are the contraindication? Unengaged fetal head. So you should not apply the forceps when the fetal head is not engaged in the pelvic cavity. Okay, so that time you should avoid the application of forceps. Then non-willing patient, the patient is not refused to do the procedure, then you should not compel the patient, you have to take the alternative methods. Okay, like emergency cesarean section, we can change it. Then bleeding disorders of the fetus, the fetus is diagnosed in the uterus itself. If the fetus is having any kind of bleeding disorder, then you should not apply to the forceps to the mother to get the delivery. Then in prerequisites are not fulfilled. Okay, so before starting the procedure, we are going to assess the mother whether the mother condition is fulfilled for the procedure or not. Okay, so then if it is not fulfilled, then you should not apply the forceps. So what are the prerequisites here? The forceps itself, the prerequisite. Okay, so what is the prerequisite we are going to see now? First things, F. Okay, so the F refers to fully dilated cervix. Okay, fully dilated cervix. The second one is O. O refers to occiputo anterior or occiputo posterior or other suitable position. So when the fetus is there in the occiput anteriorly or occiput posteriorly, or it may be the other suitable position, then we can apply the forceps. Then R refers to rupture of membranes. Before applying the forceps, you have to make sure that rupture of membrane is occurred. Okay, then C refers to consent should be obtained. Okay, but verbally as well as written consent should be taken from the family as well as the patient. Okay, then E refers to effective uterine contraction, and uterine contraction also should be present in the mother, and empty the bladder before applying the forceps, and engaged head. Okay, so always you should apply the forceps when the fetal head is engaged. Then episiotomy should be performed again to easy delivery. Then epidural or regional anesthesia can be provided with the experienced obstetrician, also one of the E stand for. Okay, then other things like uh, next one is P. P refers for the position of the head. Okay, must be known. Okay, so here the baby head, the baby position in the uterine cavity, in the pelvic cavity, that should be noted before applying the forceps, and as well as pediatrician should be present in the labor ward. Okay, so when it is an abnormal condition or when the mother or the fetus is in the risk, when you are identified, then in the fetus is pediatrician should be present, because immediately should be provide the newborn assessment. Then patient should be in the lithotomy position. Then S refers to for the sagittal suture should be on the anterior posterior diameter. So sagittal suture, that like example, the vertex part should be on the vaginal area. Okay, or it should be on the presenting part. So that time we can be apply the forceps. Okay, so these are the prerequisites in the forceps itself it's standing. Okay, so all this should be checked before applying the forceps. Okay, so when the patient is fulfilled with all these requisites, then we can apply the forceps delivery. Okay, so technique of application. So what are the technique of application when we are talking? First one is preliminaries. Preliminary assessment should be done. Okay, so all prerequisites, that is forceps. Okay, that is a forceps should be fulfilled for the patient. Okay, then select the appropriate forceps for application. We discussed 4 types of application, correct? So after identifying the prerequisite, we can come to know that what type of forceps we can be applied. Okay, so it may be a mid forceps or the outlet forceps or the high forceps. Okay, we can apply to the mother, okay, to get the delivery. Then an assistant and pediatrician should be present before commencing the procedure. So you should have the assistants and you should have the pediatrician when we are going to start the delivery of the forceps. Okay, then steps for forceps application. First one is identification of forceps blade. Okay, so first things we are going to identify the forceps blade. The second one is introduction introducing the left blade of forceps to the with the help of right hand. Okay, under the guidelines of right hand we have to apply, and introduction of the right blade by the forceps, then the ideal position of the blades relatively to the fetal head. Okay, so first things, by the right hand we are taking the blade, we are identifying the forceps, taking the using the right hand we are taking the left blade and we are introducing to the cervical os, okay, to the cervical os to the uterine cavity to hold the fetus. Okay, the second one is again the another blade should be taken and you have to introduce the other side. Okay, then after that you have to lock. Okay, then after identifying the position you should lock the things and you should uh, track. Okay, so traction should be taken in the downwards and upward, and posteriorly you should be pull out. Okay, so horizontal traction looking of the blade, and downward traction, horizontal traction and upward traction. So this is the method of delivering the fetus by forceps. Okay, so here I given the pictures. So techniques of forceps application: identifying the blade and introducing the first blade, then second one is introducing the second blade after positioning, then positioning the blade and downward traction, horizontal traction, upward traction. So this is where you have to take out the baby out. Okay, so this is the forceps delivery. So what are the complication of forceps delivery? There are definitely complication will be there in the forceps delivery. So first things, maternal complication. Maternal complication include vaginal and cervical lacerations. Okay, the lacration can happen, and extension of episiotomy wound. So when you are performing forcefully, there is a chance to develop the episiotomy wound to extend and it will make the episiotomy wound. Then postpartum hemorrhage, PPH can occur, and shock anesthetical hazards will be there, and rupture of uterus, pelvic hematoma. Okay, and also infection after delivery, the mother may have the infection due to the episiotomy wound. Okay, then painful scar in the perineum, painful coitus and back strain. Okay, fecal incontinence, stressful in urinary incontinence, vaginal vesicovaginal fistula, and these are the maternal complication will occur to the mother. And what are the fetal complication will occur to the mother? The fetal complication include lagration and brushing of the fetal skull. Okay, there is a chance of making the injury into the fetal scalp. Okay, and intracranial injuries, it may leads to the intracranial injuries, and cephalohematoma. Hematoma may be formed due to the pressure on the head, and fracture of skull may occur when we are not practiced. Okay, the experienced obstetrician also very important. When the experienced obstetricians can be perform this kind of procedure. A neurological injury to the fetus, that may lead to the facial palsy, and hypoxia may occur, and rarely intraventricular hemorrhage, and even death can occur to the fetus. So this all about the obstetric forceps delivery. Okay, so under the obstetrical operation, forceps delivery. The I hope you would have understood this. So the next one is vacuum extraction. Okay, so vacuum extraction also it's known as ventus, we can tell. Okay, so what is vacuum extraction? So, and make sure that when the mother is going on this procedure, okay, it may be the induction. During induction also we can apply the forceps to get the delivery. Okay, when it is second stage is become long time, when it is taking second stage long time, we can apply the forceps to take out the baby immediately. The head delivered, the remaining will be delivered spontaneously. Okay, that time. And one more thing is very important, that either vacuum or forceps can be applied. You should not perform both. One failure means another one you should not be perform. Either one only you should perform, either forceps delivery or either vacuum delivery or the ventus. So what is ventus or the vacuum? Ventus is an instrument. It's a special instrument to track the fetal head during the second stage of labor. Okay, so you can see here the instruments which I given in the pictures. It have two compounds, that is suction machine with a suction cup. Okay, so can be made by metal or celastic. Okay, so this is the suction cup. Okay, so suction machine will be there, so the tube will be connected to the machine and creating the vacuum pressure, applying this portion on the fetal head, and we are getting the delivery of the fetus. It's known as vacuum extraction. Okay, so again, prerequisite should be done like a forceps. Okay, so same forceps, each one, no, you should be checked before applying the vacuum also. So all fulfilled means then we can start the procedure. So again, it here indication and contraindication. So what is indication of this procedure means maternal distress, when the mother is there in the distress, especially in the second stage. So as again I told, the obstructed labor or the prolonged labor, and it is taking, then we can apply the either forceps or the vacuum. Okay, then fetal distress in the second stage. Again, the fetus is identified that in the second stage the fetal is having distress, to take immediately we can apply the forceps or in the vacuum. Okay, then prolonged second stage, deep transverse arrest. Okay, when the baby is arrested in the pelvic cavity, okay, in the transversely, then we can apply the what is that, ventus or the extraction. Okay, vacuum extraction. And medical disease like a preeclampsia condition, when the mother is diagnosed with a preeclampsia condition, to cut short the second stage labor we can apply, because it may not leads to the complication to the mother. Then contraindications, operator inexperience. Okay, the procedure should not be performed when the obstetrician or the person who does not have experience in conducting the delivery of vacuum. Then inability to assess the fetal position. Again, when the fetus position is not identified or not assessed properly, then you should not perform this procedure. And high station, and main things, the fetal station is -1, -2, -3 above the ischial spine, then you should not perform this procedure. Okay, then the fetus is present with the face and brow and other non-vertex presentation. Okay, so a suitable position for this was longitudinal lie with a vertex presentation. Okay, the fetus is in vertex presentation, because the cup should be applied on the vertex. Okay, so there you should apply. So if it is other than the vertex presentation, you should not perform the procedure. Then fetal less than 34th weeks. Okay, that gestational week. Okay, it is below 34 weeks or below 37th week, you should not perform the this procedure, extraction. Okay, vacuum extraction you should not perform. And fetal coagulopathy. Okay, so fetal identified that any conditions, okay, in the fetal stage itself, then you should not perform. And known macrosomia. Okay, what is macrosomia? Macrosomia, it is the large size of baby or big baby. Okay, so baby is there more size, okay, big size, then you should not perform, because it may leads to the mother complication more. Okay, so when you are applying the vacuum, the cup may not be the pressure may not be take out the baby out, or it may leads to the perineal lagriations, or the wound can happen in the perineum. Then recent blood sampling, the fetus is underwent to the diagnosis procedure in the during antenatal in the third trimester, and you should not perform this procedure. So these are the some of the contraindication of this procedure. Okay, so what is the technique of ventus extraction or vacuum extraction, prerequisite should be checked, preliminary assessment should be done. Okay, the ventus operator should be properly assigned and check for the working condition. Okay, whether the vacuum machine and pressure is creating and how much the volume of pressure is there, everything you should be checked out. All the tube is connected properly, everything is done or not, that should be checked before applying the cup to the fetal slab. Procedure, first step, application of cup. Okay, so this cup is introduced into the vagina with a center over the sagittal suture, that is between the 2 to 3 centimeter in front of the posterior fontanelle. So you know fetal skull is having the posterior fontanelle and the anterior fontanelle. So you can see here that there is a application of cup in the vertex. Okay, that is before just between the gap. Okay, so in the sagittal suture, so this is the sagittal suture. On the sagittal suture we are going to place the cup. Okay, then episiotomy may or may not be performed. Okay, so mostly in the what is that, in the preemie mother always there is a chance of performing the episiotomy. Okay, so you can see here the cup is placed on the sagittal suture in the vertex presentation. The baby is there in the vertex presentation. The second one step is creation of vacuum. So the machine is there. Okay, in the machine we are going to create the vacuum pressure. Okay, so that is after placement of cup, initial vacuum is 0.2 kg per centimeter square. Okay, so should be, that is the initial vacuum should be created, and gradually we can increase the vacuum. Okay, so that is 0.1 kg per centimeter square per minute we can increase 0.1 kg. Okay, so that is 1 minute we can increase. Ideal is 2 what is that, 0.2 kg. Okay, so initiation of the vacuum is 0.2 kg, and gradually every minute we can increase the vacuum is 0.1 kg per meter square. Okay, centimeter square. Okay, and to achieve the maximum vacuum, what is the maximum vacuum we can create means 0.8 kg per centimeter square. Okay, we can increase the vacuum up to 0.8 kg. Okay, so that is the vacuum we can create, and it will be like 8 to 10 minutes it should be done. Okay, so how much we are starting with 0.2 kg. Okay, by centimeter square. Okay, then up to 0.8 kg. Okay, so up to 0.8 kg within the minute of 8 to 10 minutes. Within the minute of 8 to 10 minutes, each minute we can increase the vacuum pressure is 0.1 kg per centimeter square. Okay, so this is the steps to creation of vacuum. Okay, so when you are creating the vacuum, what will happen, it will go on the cup, no, it will go and catch the fetal head. Okay, so it will get, and we are going to just pull the we can track the baby head down. So that is the main point of this creation. What is that, creation of vacuum. So the third step is traction. Okay, so after applying the pressure, what we are going to do, we are going to make the traction. We are going to do the traction. By traction the fetal head will be delivered. Okay, so traction is given at the right angle to the cup intermediately along with the uterine contraction and maternal explosive effect in the direction. So when you have to track, we have to track the cup when the mother is having the contraction. So when the mother is having uterine contraction, ask the mother to push the baby down. Okay, you have to make the mother to push the baby down, and with the help of traction, okay, then we have to deliver the fetal head. So a general principles, if there is no advancement in the 4 successive traction or the pull, okay, you should stop the procedure, or in the time is going more than 20 minutes, then we should stop this procedure immediately. Mother can shift to the emergency cesarean section. Okay, so that is the one of the important things. Then so in this, during these things we will tell cup pop-up. What is cup pop-up means? Deattachment of cup can be occurred when the creation is not happen properly. Okay, when you are not creating the pressure not properly, then cup pop-up can be occur. In such circumstance, what you have to do, you have to stop the procedure and we have to shift the mother to the cesarean section. Okay, that is the one more important thing. Then post-operative care and treatment. Post-operative care and treatment include the parent should be patient should be reassessed for the pump for the newborn's head will be disappear soon, because application of creation of pressure, no, so the baby head will become, it's like a it changes will be there. Okay, so that will be usually normal. After some duration it will be disappear, so that you have to advise the patient and the family. Okay, that is the thing. And comparison of vacuum extraction with the forceps. What is the comparison between the forceps and the vacuum? Means both forceps and ventus are effective and safe modality for the assisted vaginal delivery. Okay, so with the help of forceps also, with the help of vacuum also, it is more effective when we are performing the assisted vaginal delivery. But in obstetrician should be well trained with the procedure. Okay, so that is very important, and both are complementary each other. Okay, the choice of instruments depends upon the clinical situation. So what is the condition of the mother and what is the condition of the baby, accordingly we can select whether the mother can go for the forceps delivery or the vacuum delivery. Okay, then always you have to avoid that using the one by another method. Like example, once forceps is applied and it's failure, then you should not apply the vacuum. Okay, so you have to abandon that condition, then we have to shift the mother to the cesarean. Or you have to, first things you are performing the vacuum delivery and it's got failure, and again you should not apply the forceps, so we have to take the alternative things only. So both you should not try for the mother to get the delivery. So that is the thing. And some of the complication here of vacuum extraction, they are less common in the maternal complication because it may not affect many things to the mother like a forceps delivery, but vaginal hematoma can happen, or vaginal tear can happen, or the lacration. Okay, so perineal tear can happen because due to the large size of the baby, or suddenly when we are forcefully we are taking the baby out, sometime it can happen. Other than that, it may not leads to many complication to the mother, but in the fetal complications are more here because it's the cup is applied on the fetal skull. Okay, so that is cap cephalohematoma can happen. Okay, then subglobular hematoma, intracranial hemorrhage, neonatal jaundice, aspasia, and clavicular fracture. Okay, sometimes what will happen, clavicle bones get fracture. Okay, then injury to the 6th and 7th cranial nerve, rarely fetal death can also occur. Okay, so this is about the vacuum extraction. I hope you understood the forceps as well as the vacuum. Okay, so both are vaginal assisted vaginal delivery, we will tell. Either one only you can use. Okay, either it may be a forceps or either it may be the vacuum we can use to deliver the things. And mainly things you have to make sure that this both are used when the mother is having the distress in the second stage of labor, or it taking the long time, prolonged labor. Okay, when the woman is on prolonged labor in the second stage, or to cut short the second stage, we can use the forceps or the vacuum to deliver. Okay, so both the procedures you have to check the prerequisite of forceps. After checking the prerequisites, then you can start the procedure. After starting the procedure, you should not stop in between, and especially when the vacuum, if it is a failure is occur, then within 20 minutes it should be successfully how to deliver the head. If it is not happening, you have to stop the procedure. Again, you should don't stand in the procedure, and for the long time it may leads to the fetal distress. Okay, for the forceps, you have to identify the forceps, which forceps should be applied after prerequisite. Then you can apply, then you can traction should be taken and the head will be delivered. So this is the forceps and the vacuum delivery. So next topic we'll be discussing about obstructed labor in the abnormal labor. So what is the meaning of obstructed? Means it's getting the narrowing on the pathway. Okay. So obstructed labor means failure to progress the labor due to the mechanical obstruction. So any obstruction is occur in the pathway. Okay. So that is known as in the obstructed labor. Okay, we can tell the passage of fetus is through the birth canal. Okay, so when it is coming through the birth canal, the passage, that means 4P, passage, passenger, pathway. Okay, so when the pathway is getting become narrow and the baby, the passenger cannot be come out. Okay, so that is known as obstructed labor. So obstructed labor means failure of progress of labor to the mechanical obstruction. Okay, so due to the passage of the fetus through the birth canal. So that is the definition of obstructed labor. The causes, the etiology means malpresentation, malposition, one of the causes for the obstructed labor, or we can say CPD, that is cephalopelvic disproportion, and contracted pelvis. Woman is having contracted pelvis other than gynecoid pelvis, then they may have the chance to get the obstructed labor. Then big size baby. Okay, the baby size is become macrosomic baby, we can tell, or big size baby, we can tell. And abnormal uterus. Okay, the uterus is having any abnormalities, then it may leads to the obstructed labor. And soft tissue obstructions. Okay, any the tissues around the cervix or the perineal muscles, okay, vaginals. Okay, so that may tumors may found in the area, that may leads to the obstruction. And deep transverse arrest. Okay, the babies that are in the deep transverse arrest, that time it can occur the obstruction. Then shoulder dystocia condition also, it may leads to the obstructed labor. Okay, so these are the some of the causes. What are the risk factors? What are the risk factors means extreme age. Okay, the mother is having the extreme age of maternal age, that may leads to the obstruction. Poor nutrition, the mother is not taking the proper nutrition during the pregnancy time, that may leads to the conditions. And previous obstructed labor. Okay, the mother is already have experienced in the previously obstructed labor, that may be the chance to develop the second time also. And short stature. Okay, those are having the short stature, that may leads to the obstructed labor because they may have the pelvis different size. Okay, then pelvic deformity and premature rupture of membranes is occur. And induction times. Okay, induction of labor time also, it may leads to the obstructed labor. So these are the some of the risk factors, we can tell. Okay, then clinical features. What are the clinical features of obstructed labor? The labor pain will start continuous, but no progress will be there. Okay, so the labor will be started with the true labor pain and cervical dilatation may occur, but there is no progress, further progress will not be happen into the mother in the labor. Okay, then no descent of presenting part. No descent of presenting part means the fetal head. No, so example, you see here, the fetal head should come down, okay, in the pelvic cavity. So that may not happen because of the obstruction. Then cervix, when you're talking about cervix, there will be no dilatation. So because when the fetal head is coming down, and it will leads to the cervical dilatation. The fetal head itself not coming down means that may not leads to the cervical dilatation. There will be no cervical dilatation. So this is one of the clinical features, we can tell. Then molding will be increases. Okay, so here the fetal head will get molding, so that will be increases in this condition because uterine contraction is there, but due to the obstruction there will be no progress in the labor. Okay, so obstruction will make baby to push down. Okay, but due to the narrowing space or due to any kind of mechanical obstruction, the baby is not coming down to the birth canal. Okay, so that may leads to the increased molding. And maternal exhaustion. Okay, the mother may have the distress, exhaustion may happen, and tachycardia and dehydration, and fetal Trachycardia also will be present. Okay, so fetal distress will be present. The fetus will be in the risk. Okay, so fetal distress will be more in this obstructed labor, as well as PROM. What is PROM? That is premature rupture of membranes. Okay, premature rupture of membranes are one of the clinical features. Okay, then tender abdomen. So the abdominal will become tender. So these are the some of the clinical features. Okay, so this may occur into the obstructed labor. Okay, then what is the diagnosis should be done? First thing, history should be collected, because previous also it may be the one of the risk of factor, and this other condition is present or not. Okay, malposition, malpresentation, or CPD. Okay, or the baby size is big, so that history should be collected. Okay, so onset of labor, when the in the history include onset of labor, duration of labor, and the duration and frequency of uterine contraction, and previous obstetrical history also should be collected to diagnose the condition of obstructed labor. Then clinical examination. So after physical history collection, clinical examination should be done. The clinical examination include the general condition with the vital signs. Okay, general condition should be assess the mother, and vital signs should be checked, and per vaginal examination should be performed. So vaginal examination, what are the things you will be seeing? Dilatation of the cervix, whether it happened or not. Okay, and what is the centimeter of cervical dilatation, that should be checked. And fetal station should be identified, whether the fetus is engaged or not, or the what is the fetal station of the baby or the fetus, that should be identified. Then position should be identified. Okay, so position is should be identified in the vaginal examination. And molding, okay, molding also can be identified in the vaginal examination. Okay, then abdominal examination should be performed, because one of the clinical features I told, tender abdominal pain will be there. Okay, so tender abdominal will be there, so that should be checked out. And uterine activity, when you are doing abdominal examination, we can identify the uterine activity, tenderness. Okay, and also you have to perform the fetal heart rate, that is auscultation you should perform to identify the fetal heart rate. Okay, so what is the fetal normal fetal heart rate? That should be 120 to 160 per minutes. Okay, beat per minute. So that should be checked out. Okay, in the diagnosis. So this is the diagnosis will be made it out of. Okay, then management. So what is the management you will be doing for this obstructed labor? General management include the things like explain the condition to the mother and reassure the conditions. Okay, so what is the reason the mother is stuck in the progress of labor, that should be checked out. Then IV administration of IV fluid should be done immediately, because maternal extraction and dehydration may happen, so that should be prevented. Okay, and that preventing that complication, you should put the mother on the IV infusion, and monitor the vital signs, monitor the fetal heart rate, and monitor the uterine contraction. Okay, then mother should be put on the catheter to make the bladder empty. Okay, the catheterization should be done. And next one is pain killer should be provided, because the mother is having the pain will be there, so painkiller can be provided in the form of along with IV only. Then emotional support should be provided as a general management. Okay, then specific management. So specific management include according to the identification of which is the causes for the obstruction, accordingly we are going to provide the general management. Okay, if you are identified that CPD, that is cephalopelvic disproportion, is the leads to the obstructed labor, then you have to shift the mother to the cesarean section. Okay, that you have to provide the cesarean section. Then if you are identified the mother with malposition and malpresentation, then correct, if it is possible, you can correct the version procedures can be performed, then you can correct the malposition or malpresentation, then you can perform the delivery. If it is not, you can go to the cesarean section. Okay, that is the specific management for malpresentation and malpresentation. Then soft tissue abnormalities. Okay, soft tissue abnormalities, you can perform the relative obstetric, especially the cervical incision. Okay, and removal of tumor, that can be performed okay, before to the labor itself. Okay, then fetal distress, if the fetal distress, it is a condition in during that time, okay, fetal distress is there, then what is the management you can provide? Means that is forceps delivery or vacuum delivery can be performed to cut short the labor or to make the baby out immediately. Otherwise you have to perform the cesarean section, emergency cesarean section with the LSCS. Okay, then rupture of uterus is the rupture of uterus or in conditions, then that time also you can perform the emergency cesarean section. Okay, so first things, when you are identified that the mother is on obstructed labor, you can go directly to the cesarean section to prevent the further complication to the baby as well as the mother. Okay, so the management include general and specific management I told. So complications, okay, what are the complications will occur to the mother? Maternal rupture. Okay, so maternal rupture can occur, that is uterine rupture we can tell. Okay, in the maternal complication, uterine rupture will occur. Postpartum hemorrhage, PPH is the one of the complication, and shock, the bleeding may leads to the shock, and sepsis, perfural infection can occur to the mother, and injury can happen in the bladder as well as in the perineal. Okay, and fetal fistula formation can occur, and maternal mortality can happen. Okay, these are the maternal complication. What are the fetal complication? Fetal distress will be there, birth asphyxia will be there, and molding may leads to the danger to the fetus, and intracranial hemorrhage can happen, and fetal trauma as well as prenatal mortality. Okay, prenatal mortality can happen. So these are the complication of obstructed labor. Okay, so what is the nursing management you will be provided to this condition? Continuous observation for both mother and the fetus is required in the labor, because labor time. Okay, so to identify the progress of labor, maintaining the pathograph is very important. Okay, and monitoring the maternal and fetal conditions regularly. Okay, so every 15 minutes you have to identify, you have to check the mother condition as well as the fetal condition, and maintaining the IV fluid for the mother, it's very important to make the electrolyte imbalance. Okay, that is to prevent the heat dehydration, and encourage avoiding the avoiding by mother to be on the encourage the mother to not to cope up. Okay, then psychological support should be provided, and prepare for always emergency cesarean delivery in the labor. Okay, so this is the what is it, nursing management of obstructed labor. Hope obstructed labor is understood. Next, we will discuss about prolonged labor. So, what is meaning of prolonged labor? The name itself is there. Prolonged means long time. Okay, taking long time. So, definition: prolonged labor is a labor that exists more than the normal duration. Okay, so especially in the first stage or the second stage. Okay, so then we can consider as a prolonged labor. It have the different types of prolonged first stage labor. That is, first stage of labor is taking the dilatation of the cervix. So it is normally preemie mother. It may be leads to 6 to 8 hours. Okay, so sorry, 8 to 8 hours. 10 centimeter cervical dilatation should be taken. Okay, so 8 to 10, 12, 10 hours also it will be, sometimes it depends upon the mother conditions. Okay, so when it is taking more time, okay, more than example, plus or minus plus 8 hours is taking, okay, 6 hours is taking, then it is known as prolonged first stage labor. Okay, so that is active space of prolonged labor is leads to more than 12 hours, and are in the null in the what is that, in the preemie mother, more than 12 hours is taking only the active space. Okay, then more than 10 hours is taking for the multipara mother, then it is diagnosed as a prolonged labor. Then the second type is prolonged second stage of labor. Okay, prolonged second stage of labor, that it is like more than 2 hours in the preemie mother. Okay, first time delivery mother, if it is taking the second stage is comparing to the normal plus 2 hours is taking, that may leads to the prolonged diagnosis of prolonged second stage. And the multipara mother, it's taking more than 1 hour. Okay, it may be 30 minutes only for 5 to 5 to 30 minutes is the second stage of labor for the multipara, and that is taking more than 1 hour. That may be diagnosed as a second stage prolonged labor. Okay, and the third type is prolonged third stage labor. So you know, third stage labor is a placental delivery. It is normally up to 30 minutes is the normal for both premi or the multipara. It is a 15 to 30 minutes, it's the normal duration. Up to 30 minutes we can consider as a normal, but when it's taking more than 30 minutes, okay, when it's taking more than 30 minutes, that may be diagnosed as a prolonged third stage of labor. Okay, so prolonged labor, it's include types include first stage labor, second stage labor, third stage prolonged labor. Okay, so what are the causes of this what are the causes of this prolonged labor? It may be the 4P. Okay, so that is power, passenger, passage, and psychological factors. Okay, so what is power? Poor uterine contraction. When the woman is having the poor uterine contraction, we can tell hypotonic uterus. Okay, the uterus is become hypotonic uterus, then it may be the leads to prolonged labor. Okay, P4. Okay, power, passenger, passage, and psychological factors. Okay, so the second one is passenger. Any abnormality in the passenger. Here, who is the passenger? Fetus. Okay, large size fetus example. Okay, so that may take delay to come descent to take or malpresentation in the fetus, or in the multiple pregnancy, means twins pregnancy, it may be the reason to take the prolonged labor. The next one is passage. Okay, passage. Where is the passage? It's happening when here the pelvic cavity is the passage. Okay, because through the pelvic cavity only the baby should come out, the fetus should come out. So here any abnormality in the passage, means example contracted pelvis or obstruction is happening. Okay, the previous condition we discussed now, obstructed labor, that also may leads to this prolonged labor. Then psychological factors include fear, anxiety, pain. Okay, so that may leads to the condition prolonged time. Then maternal factor include extreme age. Okay, the mother is having extreme age, malnutrition, anemia, and maternal exhaustion, and medical disorders. Okay, so these are the some of the causes of prolonged labor. The next one is clinical features. So what are the clinical features of this prolonged labor? Slow progress in labor. Okay, so slow progress will be there. So the next one is weak uterine contraction will be there. Okay, the next one is maternal exhaustion will be there, and dehydration will be present, and fetal distress will be there. Okay, then bladder distension. Okay, so is an obstruction can occur in the obstructed labor can occur in the mother. Okay, so that is the clinical features of prolonged labor. Then diagnosis, again history collection should be taken. So what are the history should be taken? Same like obstructed labor. Onset of labor should be taken, duration of uterine contraction should be checked, and show should be checked. What is show? The mucus plug, no, that come out. Okay, what is the time? What the time the mucus plug is come out? Rupture, when its rupture is occur. Okay, all these things should be checked in the history, and previous obstetrical history also should be checked out. Okay, then clinical assessment. Clinical assessment include the general condition and vital signs. Okay, that should be checked out. Then contraction, the strength, duration, frequency. Okay, the uterine contraction should be checked out. Strength of uterine contraction, frequency of uterine contraction, as well as the duration of uterine contraction should be checked out. The next, per vaginal examination. The per vaginal examination, what are the things you should be identified? Means dilatation of the cervix and fetal station, and fetal molding. The fetal head molding should be identified, and position of the fetal head should be identified. Then auscultation include the fetal heart sound. Okay, fetal heart sound should be checked out. Then urine output. Okay, urine output should be checked in the diagnosis, and dehydration, because mother may leads to the prolonged labor may leads to the complication of dehydration. So for that, dehydration assessment should be done. So these are the things you can identify in the diagnosis. Then management, the management include the general management. So generally you will be reassuring the condition and explain the condition to the mother as well as the family to understand the condition of the labor progress. Okay, the next one is provide privacy and emotional support. Okay, so under generally we have to provide the privacy to the mother as well as emotional support should be provided, and encourage to mother to take oral fluid, okay, and light diet, okay, and allow the ambulations, means make the mother to be move around if it is in the first stage labor prolonged, okay, not in the second stage, first stage labor, and encourage the bladder to empty and maintain the hydrogen and nutrition, and relieve the pain by anxiety. Okay, so relieve the pain and anxiety of the mother. So these are the management. General management include and specific management include weak uterine contraction. If you are identified that weak uterine contraction, IV fluid could be provided, that is oral or NSP administered with IV infusion, or injection of oxytocin. Okay, injection of oxytocin can be provided 5 to 10 units, okay, in 500 ml of oral, and 20 drops, okay, 500 ml of oral in 20 drops per minute can be provided, okay, and if it is ruptured membranes with no progress, okay, so rupture of membrane is there and there is no progress of labor, then evaluate the conditions, and with oxytocins, again if it is safe, oxytocin drip should be administered, that will be the safe. Antibiotic should be provided because it is rupture is occurred, so mother may leads to later infection, so antibiotic can be provided. The next one is cephalopelvic disproportion, that is CPD is there, then mother can go for the cesarean section. Immediately mother can shift to the cesarean section. If it is malpresentation also, if it is able to correct the malpresentation and malposition, perform, then can conduct the delivery with the help of forceps or the vacuum. Otherwise you can shift the mother to the emergency cesarean section. Then fetal distress is the things, if it is present in the prolonged labor, then immediately delivery of the baby with the help of forceps or the vacuum. Otherwise the mother can shift to the emergency cesarean section with the LSCS. Okay, so this is the specific management of prolonged labor. The nursing management include assess the mother and the fetal conditions regularly, and monitor the vital signs and fetal heart rate, it's important, and maintain the pantograph, because through the pantograph only we can identify this condition as well as the previous condition, whether the mother is obstructed labor or the prolonged labor. That is one of the main reason to diagnose the condition, pantograph. Okay, and provide compatible measures, okay, and encourage mother to take fluid, okay, or administer the IV infusions, and assist in the ambulation, early ambulation in the first stage of labor, advise the mother to go for a walk, okay, because that is very important, and administrator of drug is as per the prescription, and prepare the possible operative delivery. If it is forceps, immediately arrange it. With the help of assisted vaginal delivery, the baby can be removed out in the uterine cavity to cut short the labor, okay, and provide the postpartum care and health education to the mother. Okay, so that is the prolonged labor. Hope prolonged labor is understood. Okay, so obstructed labor, prolonged labor, little bit same. The obstructed labor may leads to the prolonged labor. Okay, so due to the mechanical obstruction labor will occur. It may be in the passage or the passenger, and the same way prolonged labor can occur in the long time. Okay, so when the labor stages of labor is taking long time, in the first stage it can happen, or in the second stage it can happen, or even in the third stage it can happen. There are main 4 P is there, correct? So what is the 4 P? That is passage, passenger, and what is it? Power, okay, and psychological conditions. Okay, so this psychological factor. So this is all about the prolonged labor. Thank you.
Sir is waiting, no? Start, sir. Hi everyone, I'm Hashita. So today we are here to start our new session which is related to assessment and management of women with gynecological disorders. So this video will be very useful for the 7th semester students as your exams is coming very soon. So let us start with the class. Yeah. Before starting our actual class, let me give some intro about our specialized subject in our nursing, that is obstetrics and gynecological nursing. You all know this. So, this is a specialized branch of our nursing which is going to deal with the woman during pregnancy, childbirth, and postpartum period, and it also includes a gynecological disorders and it includes our female reproductive system. So when it comes to the gynecological disorder, these are the conditions which includes a female reproductive system and it has or it includes uterus, ovaries, fallopian tube, vagina, cervix, and also it includes breast. So let us discuss it one by one. So we'll start with a common gynecological disorder which we can see in the woman. So let me list down that. So we can see the dysmenorrhea, menorrhagia, PID, cervical cancer, PCOD or PCOS, then breast cancer, and amenorrhea. So these are the most common gynecological disorders which we can see in the woman. So before going to explain this, let me start with the assessment and management of a woman with a gynecological disorder. So the first thing, we will be starting with the assessment. The assessment and management of gynecological disorder as much as early as possible, it is very essential to prevent complications of gynecological disorders, and as well as it improves our woman health. So we will start with the assessment. So in the assessment, there are three things will be included. So the first thing is history collection. So let's start with the history collection. So yeah, in the history collection, as you all know, the first and foremost step is identification data. So we have to identify, means we have to collect the identification data or the biodata from the woman or from the patients. Like it includes name, age, marital status, then address. So these things we have to collect from the patient or from the woman. And next is chief complaints. So the chief complaints, it's very important for us to give a diagnosis, proper diagnosis of the particular condition. So in the gynecological disorders, most commonly we can see the chief complaints like abnormal vaginal bleeding or the vaginal discharge we can see, then lower abdomen pain we can see, then menstrual irregularities, infertility, then postmenopausal bleeding we can see, and as well as pain during sexual intercourse. So these are the most common chief complaints or the signs and symptoms which we can see in the woman, those who got affected with this gynecological disorders. So the next thing is menstrual history. So the first is identification data we have to collect, and after that the chief complaints. So what are the complaints they're having? Then the next one is menstrual history. History is very important. Okay, so in the menstrual history, we are going to collect the age at menarche and age at menopause, then duration of the menstruation or the irregularities of menstruation, and also amount of the bleed, then the color of the bleeding, the vaginal bleeding, that is very important, we have to collect. Then the most of important thing is LMP, this one, last menstrual period date, we have to collect from the woman. And next is obstetric history. So when they are married, when the women are married, from the married woman, definitely we have to collect the obstetric history, that you all know, that the gravida, parity, then abortions or previous history of abortion, and also we have to collect the live children or the living children count, we have to collect from the woman. Next is contraceptive history collection we have to do. Contraceptive method, whether they have used any kind of or any type of contraceptive method to prevent the unwanted pregnancy or not. Then if they used, what is the duration of that contraceptive method, what they have used, and during that phase when they use the contraceptive method, they have, whether they have faced any complications or not, that we have to collect it from the woman. Next is we have to collect the family history. For example, whether the woman's background in their family, anybody is having PCOD or the cervical cancer or the breast cancer or any cancer of our female reproductive system, whether they're having a history of that, we should collect. And also, along with this, we have to collect the medical and the surgical history. Either it is present medical history, or it is a past medical history, or it is a present surgical or the past surgical history. We have to collect it from the woman. This is what the history collection are our first step. And the second is, first thing is, I hope you will understand this history collection. So in the history collection, we have to collect the identification data, chief complaints, then the menstrual history, obstetric history, then contraceptive history, medical and the surgical present and past medical surgical history, and also we have to collect the family history. Then next is the physical examination. So the next thing is the physical examination we have to conduct or to do to assess the gynecological disorders in the woman. So the first thing is, obviously we will do the general examinations like height, weight, vitals we have to check, then BMI, nutritional status of that woman, then anywhere the edema is present or not, we have to check for that. Next thing is systematic examination. So systematic examination in the sense, obviously it includes from the head to toe assessment we have to do system wise, from the cardio or the respiratory system, endocrine system. So systematically we have to do the examination. Next is the important thing is breast examination we have to do, like inspection, palpation, any kind of discharge in the nipple or anywhere else there is a like dimples or the dimpling in the nipples, we have to look for that. Anywhere else they are feeling lumps in the nipple, so we have to, in the breast we have to identify that. That is a very important thing. Next is pelvic examination we have to do, like a speculum examination we can do, or else inspection they can do. Then they have to conduct a vaginal examination to assess the uterus size and position. So we will call that as a bimanual examination, you already studied that. Then tenderness we have to check, then vaginal wall assessment we have to do. So this is what it includes in the physical examination, means completely from the head to toe we are going to assess the woman. So the next third one is diagnostic investigations. So the third part is our diagnostic investigations. So in the diagnostic investigations, obviously we will start with the lab test, like doing CBC, urine test, then hormonal test, or the pap smear we have to conduct, or the swab culture. We have to collect the sample from the vagina and we can send it for the culture test and all. Then they can also undergo for the imaginary test called like ultrasonography of abdomen and pelvis, or the TVS transvaginal sonography. Then they can even go with the CT and MRI. So some special procedures also we can do to diagnose the gynecological disorders, like hysteroscopy, then endometrial biopsy we can do, and the laparoscopy we can do to diagnose the gynecological disorders. So this is how our assessment part looks. So next, move on to our common gynecological disorders as I listed down earlier. So we'll start with the one by one. So the first one is dysmenorrhea. So the dysmenorrhea is like one of the most commonest condition which in our monthly days or in the monthly ones the females will be facing this. You already know this. The dysmenorrhea is a painful menstruation. So here what happens? So what is the management for this? In the sense, they can go with the first the hot application, or we can call it as hot fermentations they can go, and by doing the exercises obviously they can control the periods pain, or it's called a severe periods pain they can control. And by taking the adequate rest, then proper way of maintaining their food pattern or the lifestyle changes, and even when it cross its limits like a severe pain they are getting, they can go with the non-steroidal anti-inflammatory drugs unless it is serious or it is severe. So better if it's less, it's the pain is very tolerable, they can tolerate it with by taking this hot applications, or doing proper yoga or the meditations or a kind of exercises, then taking proper or adequate rest, they can be control this dysmenorrhea. And the next thing is the second one, menorrhagia. So what is this menorrhagia? In the sense, excessive menstrual bleeding which is occurred regular in intervals. So usually when they attend this menstrual days or the menstrual phase, they'll be feeling excessive bleeding. They can observe, that is what we can call it as menorrhagia. So it's excessive menstrual bleeding, it is called as what, menorrhagia. So what is the management for this? In the sense, obviously you know that maintaining a proper lifestyle, it is very important. Then hormonal therapy they can take, and iron supplementation for the woman, that is very very important, because as they can see the excessive bleeding in their menstrual phase. So obviously we can see the like dizziness they'll be feeling, or the cramps we can see, or the menstrual irregularities will be there, they'll be tired. So in that kind of situation or in that condition, so obviously the women are required more rich nutrition, and also the iron supplementation, it is very important. Next is amenorrhea. So menorrhea, in the sense, obviously you all know that is what, bleeding or menstrual bleed. A, it is indicates what, absence. Okay, so always the A indicates what, absence. Menorrhea, in the sense, it is a menstrual bleed. So absence of menstrual bleed, it is known as what, amenorrhea. So there are certain causes of this. For example, when the women are pregnant, obviously we can see that is a common for the 9 months there is no vaginal bleeding. Then when the women are having excessive workload or the stress, frustrated, now the words are like depression, it's very common, they'll be saying that I have a stress, I have frustrated, I have depression. So because of this workloads or from pressure from their lifestyle pattern, so they'll be having irregular menstruations, or they'll be having a amenorrhea. And there is a cause also we can include, that is a hormonal changes in our body. Then also it is because of PCOS, so polycystic ovarian syndrome, or the changes because of this hormonal imbalance in our body, we can see the absence of menstrual bleed. Next is how we can treat, in the sense, we have to treat based on the underlying causes. So if it's because of stress or if it's because of frustration, then we can give that woman. So based on the underlying causes, we have to give a treatment for this amenorrhea. And even they can go with the hormonal therapies, and they can go with the nutritional supplementations or the nutritional counseling they can go. Next is, so the next thing is polycystic ovarian syndrome or the polycystic ovarian disorders. So this is the most commonly now the women are facing this PCOD. All the women will be having the complaints of menstrual irregularities. There is a cyst in their ovaries. It's become a quite common nowadays because of endocrinal hormones imbalance in our body. So there will be a production of cyst, which we can see in the ovaries, and which is characterized by the ovulatory dysfunctions and polycystic ovaries we can see. Means there is a multiple small cyst which is present in the ovary. So what are the signs and symptoms usually we can see in this PCOD or the PCOS? In the sense, acne over their face, then we can see the hair loss and more weight gain, or we can call it as obesity. Then infertility is also one of the symptom, and irregular menstrual cycle. Their menstrual cycle will be around like it's 1.5 month. They'll get menstrual bleeding or more than 45 days. So these are the signs and symptoms which we can see in the polycystic ovarian syndrome. So the next one, the what is the management for this? In the sense, obviously they can go with the hormonal therapies. If it's infertility they are facing, they have to go with the fertility treatment. Then doing the regular exercises or doing regular meditations or the yoga, they can control the imbalance of our endocrinal hormones. And weight reduction is also one of the management which they have to do. And the moreover, they have to change their lifestyle. So whatever, like having the junk foods or the oily foods, that and all, it must be controlled. So the next is uterine fibroids. So the uterine fibroids or the benign, it's a non-cancerous, we will call it as, okay. It's a benign or the non-cancerous tumors which is present in the smooth tissues or the smooth muscles of our uterus. So it's a non-cancerous, it's not a cancerous one. There is a non-cancerous cell growth or the smooth muscle development which we can see in the uterus. So what is the cause of this? In the sense, increased estrogen production is one of the cause. Then there is a family history of uterine fibroid, and also if the women are at the age of reproductive call 30 to 35 years, that is also, so age related, it is one of the cause. Then obesity and also the early menarche is one of the cause of this uterine fibroid. So what is the treatment for this? In the sense, they can go with a non-steroid anti-inflammatory drugs, and as on also they can go with the hormonal therapies. When it becomes severe or the sizes of that sizes and the multiplication of that cells it is increased, they can go with the myomectomy and also with the hysterectomy, complete or the partial removal of the uterus. Then the last one is PID. So PID, it's nothing but pelvic inflammatory disease or the disorders. So this is infection of upper female reproductive tract, which includes uterus, fallopian tube, then the cervix it includes. Then complete reproductive tract, upper reproductive tract will be included, surrounding the pelvic tissues and the ovaries, fallopian tube, uterus, everything will be included. It has got infected and inflamed. That is what we call it as a PID. So here, what is the management or the PID of for this? In the sense, antibiotics, the initial stage, they have to take the antibiotics and complete rest for their body, and the adequate hydration, it is very much important. And doing a pelvic exercises, it is very important to get a support for the pelvic muscles. And next is cervical cancer. Yeah. So the cancer is what? The cancer is abnormal cell growth or the abnormal proliferation of cell in the cervix. We can see there is abnormal growth of a cell or the proliferation of a cell which is present in the cervix. So what is the diagnostics test to identify the cervical cancer? In the sense, obviously they have to go with the pap smear, and they have to do the biopsy. So biopsy is the very important diagnostic test to identify or to rectify whether it is a cancerous or it's a non cancerous. Then what is the management for the cervical cancer in the sense in the initial stage they have to get it done with the chemotherapy, radiotherapy, and even they can, if it's a severe, they can go with the surgeries. So that's all about the assessment and management of women with a gynecological disorder. So hope you all understood what are the most common the gynecological disorders which we can see in the woman, and as I said before, the early diagnostics and early assessment of gynecological disorder, it's very important for us to give a proper health and improve the proper health of a woman and to prevent all those complications. So yes, so that's all about today's session. Thank you all.
Hello everyone. So now we will be discussing about the postnatal complications. So under this postnatal complication, there are five main topics I will be discussing in this section. That is, first one is PPH, that is postpartum hemorrhage. The second one is perfural sepsis. Okay. The third one is breast encroachment, and the fourth one is postpartum blues, and the next one is postpartum depression. So this five condition we will be discussing in this section. So first one is postpartum hemorrhage, that is PPH. So what is PPH? PPH means it is postpartum hemorrhage. After the delivery, the excessive bleeding is known as postpartum hemorrhage. Okay, so in the definition we can tell postpartum hemorrhage is the excessive bleeding after the delivery. Okay, so that is diagnosed as a postpartum hemorrhage. So how you will be identified that, because vaginal bleeding is a normal after the delivery. So how you will be identified means, in the vaginal delivery 500 ml is the normal. In the cesarean section 1000 is the normal. So when it is going more than this in the condition, okay, so that condition is diagnosed as a PPH. Okay, that is diagnosed as a PPH. Okay, then types, there are two types of PPH is there, primary PPH and secondary PPH. So primary PPH, when you are talking, it will occur within 24 hours of delivery after the childbirth. Okay, so within 24 hours when the woman is diagnosed with the heavy bleeding, okay, that is more than the 500 ml in the vaginal delivery and more than the 1000 ml in the cesarean section, that is known as primary PPH. Then secondary PPH. What is secondary PPH means? The bleeding is diagnosed more than 500 and more than 1000 ml after the 24 hours, okay, after the 24 hours of delivery up to 6th week of postpartum. Okay, so in the postnatal time till 6th weeks, if the mother is after 24 hours till 6 weeks, if it is diagnosed with heavy bleeding, that is or excessive bleeding, that is known as secondary PPH. Okay, then what are the causes of PPH? Mainly easy to understand, there is 4T we will tell. Okay, 4T is there. So what are the 4T refers to means tone, okay, that is uterine tone. Okay, so uterus does not contract properly, so that may leads to the PPH. Then tissue, the second T refers to tissue, placental pieces, okay, retained placenta conditions and all, we can take this PPH conditions. Okay, so example, retained placenta. Then trauma, okay, so trauma means cervical tear, vaginal tear or uterine rupture. Okay, so when trauma has happened in the uterus or in the cervix or in the vagina, that may leads to the heavy bleeding. So that is the third T. Okay, that is trauma. Then the fourth one is refers to thrombin. Okay, thrombin means blood clotting problems. Okay, when the woman is having the clotting problems, that may leads to the heavy bleeding. Okay, so this is the four main causes of PPH. Understood? PPH means it is a excessive bleeding after delivery. It is, if it is normal delivery, it is more than 500 ml. If it is gone, the bleeding is there, that is known as what is that, PPH. If it is cesarean section, if the more than 1000 ml is there, that is known as PPH. Okay, there are four etiology, four T, it refers to etiology, that is tissue, tone, trauma and thrombin. Okay, the next one is risk factor. What are the risk factor? It may leads to the PPH means multiple pregnancy. Okay, when the woman is having multiple pregnancy, example twin pregnancy, then it may leads to the PPH conditions. And polyhydramnios, excessive amniotic fluid is there, that may leads to the condition of PPH. Then prolonged labor, when the mother is having prolonged labor, that may leads to the PPH conditions. And large baby, because large baby, it may leads to the episiotomy. So episiotomy tear, okay, in the tear can be extended, the episiotomy wound it may happen, so that may leads to the PPH condition. And previously the woman is diagnosed with the PPH, that also may happen in the risk factor. Okay, then cesarean delivery, it's a mother is undergone for cesarean delivery, that may leads to the PPH. Okay, so excessive bleeding will be there, and mother who have anemia conditions, okay, so that also may leads to the PPH condition. So these are the some of the risk factors. Then signs and symptoms, how to identify this mother is having bleeding is the one of the signs and symptoms. Okay, heavy bleeding is the one of the things. Heavy vaginal bleeding will be there along with the blood clot. Okay, and the mother look like a mother may leads to shock. So what are the signs of shock? So accordingly in the signs and symptoms will be there, like a weakness will be there, and pale skin, and fast what is that, pulse rate will be there, the pulse rate will be increasing, and low BP will be there. Okay, blood pressure will be decreased, and dizziness, the mother will have the dizziness, and also the mother will have the cold skin. Okay, the skin will become cold, and restlessness. Okay, so these are the signs of shock. So mother will have the excessive vaginal bleeding with the blood clot, and sign of shock will be present. Okay, the next one is the diagnosis. The diagnosis made by the observation. Okay, the bleeding will be there, no? So amount of blood loss we should be identified, that input output chart after delivery you have to maintain the input output chart. So through that chart we will be identifying that the mother is having the excessive bleeding. So amount of blood loss, and vital signs, because increased pulse rate, decreased blood pressure is there, so that can be identify the causes, the conditions. The next one is uterine contraction. Okay, so uterine contraction you have to check it, and placental completeness, you have to check the placental completeness, because one of the etiology is retained placenta condition. Okay, when the placenta is not completely delivered, that may leads to the PPH conditions. Okay, then blood investigation can be done. So these are the diagnostic procedure should be done. Okay, then management. So how to treat this condition PPH, how to treat the condition? Call for help, any emergency you have to call for the help. Okay, so immediately check, immediately you can look for the help by calling the obstetricians. Okay, if it is emergency condition in the postnatal time. Then assess the mother, check for the airway, breathing, circulation, because the mother may have the shock, it may leads to the unconsciousness. So you have to check for the mother airway, breathing, circulation. So that is a second assessment you can do. Immediate management. Okay, under the immediate management I'm telling, first one for call for help, second one for the assess the mother conditions, the next one is massage the uterus. Okay, you can start massage the uterus, so it helps to contract the uterus. Okay, contraction can happen. Then IV fluid should be started to prevent the electrolyte imbalance and the dehydrations. Okay, and replace the blood loss also. It will replace the blood loss also. Then oxygen administration, if the mother is not having stable, you can provide the oxygen administration. The next one is medicines. What are the medicines will be administered immediately? Means oxytocin is the primary drug, because oxytocin, even once the uh, placenta is delivered, you can administrate the oxytocin, that will make the contraction, then that will minimize the bleeding. Okay, so oxytocin is the first line drug you can administrate. The other drug include the misoprostol. Okay, misoprostol also you can administrate to the mother who's having the PPH. Okay, then blood transfusion, if it is heavy blood loss is there, the mother is required blood transfusion, immediately you can start with the blood transfusions. Okay, the next one is surgery. So surgical management, if it is needed, you can perform with a balloon tamponated or the B-lanced suture. Okay, B-lanced suture means the suture can be done in the cervical area, or hysterectomy can be performed if it is a rupture is occur in the uterus, complete rupture is there, then you can perform the hysterectomy, that is removal of uterus can be done. Okay, so this is the surgical things, if it is needed only you can perform in the management. Okay, The next one is shock complications. So when you're talking about complication of PPH, first one is shock. Okay, the mother will have the shock and severe anemia due to the blood loss. The mother may develop with a severe anemia condition, and infection will be there in the mother. That is perfural infection we will tell, or perfural sepsis. We are going to discuss second condition. Okay, so that is a perfural sepsis may happen, and kidney failure can happen in the mother who have the PPH as a complication. Okay, the next one is maternal death. Sometimes, very rarely, maternal death also can happen in the mother. Okay, so this is the complications. And prevention, when you're talking about prevention, in the antenatal, prevention is from the antenatal care. Okay, so from the antenatal time only proper care should be provided. That is, antenatal care can be provided to the mother with a antenatal checkup. Okay, then treat anemia. If the mother is diagnosed with anemia in the antenatal, treat the condition in the antenatal before labor itself. Okay, then skilled delivery care. Okay, so the delivery care is very important. Intrapartum care is very important, that should be provided. And active management of third stage labor is very important. So active management of third stage labor, you can be performed immediately. Once the mother is delivered completely, you can provide the care, then you can shift the mother to the postnatal ward. Then next one is early identification of risk factors. Okay, so what are the risk factor or etiology we discussed? Early identification is very important. Okay, so accordingly we can treat the things. Hope understood this PPH, correct? PPH is the excessive bleeding after the delivery. Okay, so that is very important condition, very important condition of this thing. Okay, the management, nursing management, what you will do in this assessment, assess the mother condition, that is monitor the BP, pulse rate and respiration. Okay, then observe the bleeding. Okay, so observe the bleeding from the vagina, then assess the uterus. Okay, so you have to assess the uterus. And also nursing care include IV infusion with that is IV infusion with blood transfusion if it is blood transfusion is required, and give medications like misoprostol or oxytocins, and provide oxygen if it is needed, and record the intake output chart. That is very important as a nursing management. And maintain the cleanliness to prevent the infection, as well as emotional support is very important to the mother. Okay, and also you can provide the health education regarding the danger sign of PPH. Okay, because it may leads to renal failure also, so you can advise the mother about the health education and the importance of follow-up care. Okay, so that is also very important. So this all about the PPH. The second one is perfural sepsis. So what is perfural sepsis? Perfural sepsis means it is an infection. Okay, so a sepsis means refers to infection. Okay, perfural sepsis or infection is in the genital tract occurring during pregnancy or during labor within 42 hours of postpartum period. Okay, that is after delivery. It's known as perfural sepsis. Okay, that is known as perfural sepsis. It may be leads to by the microorganisms. Okay, it may be the leads by the pathogenic microorganism. There are two types of perfural sepsis. One is perfural septicemia and another one is perfural pyrexia. Okay, pyremia. Okay, so perfural septicemia means infection spread through the blood streams. Okay, bloodstream, through the blood streams the infection is spread to the mother. Okay, perfural pyremia means in septicemia with multiple metastatics. Okay, multiple metastatics, that is the two types. Okay, then what are the causes of this perfural sepsis? Ascending infections. Okay, so infection from the vagina or in the cervix. Okay, so through the cervical and through the vagina the infection, okay, can occur, that is microorganism can enter, and it may leads to the septicemia. Okay, the next one is prolonged labor. Okay, so when the mother is exposure long time. Okay, so that is prolonged labor. Last section we discussed what is prolonged labor means, taking long time. Okay, so especially in the second stage. So during prolonged labor over time there is a chance of developing the perfural sepsis. And repeated vaginal examination, when the mother is undergone for repeatedly vaginal examination during labor, that may leads to the infections. Okay, then next one is retained product of placental or conception. Okay, so any part of, no, labor means everything that is conceptional product should come out through the vagina from the uterus. So when it is retained in any part of membranes or any part of placenta, that may leads to the sepsis. Okay, the next one is poor perineal hygiene. Okay, so perineal care is very important. When it is not performed properly, that may also leads to the perfural sepsis. And instrumental delivery means, like example, forceps delivery. Okay, when the mother is undergone for forceps delivery, that may leads to the perfural sepsis. Okay, I think we discussed in the complication of forceps delivery. The next one is cesarean section, LSCS also may leads to the what is that, perfural sepsis. Then mother is having anemia, poor nutrition, low immunity power, that all things may leads to the perfural sepsis. Okay, so these are the causes. And what are the risk factors? Risk factors include prolonged rupture of membranes. Okay, so rupture of membranes occur in long time. Okay, so that is a prolonged rupture of membranes, and prolonged labor, and multiple vaginal examination. Okay, many times, frequently the vaginal examination is done, and a retained placenta or the conceptional product, and instrumental delivery, cesarean section, anemia, malnutrition, poor personal hygiene or poor perineal hygiene. Okay, so these are the risk factors. Then signs and symptoms. When you are talking about signs and symptoms, and the general symptoms may present with a fever, because infection may leads to the high temperature, it will elevate the temperature in the body, so that will be high grade fever will be there. Then chills with rigors and malaise, weakness and loss of appetite, headache. Okay, rapid pulse will be there. Okay, that is a thing. And local symptoms include lower abdominal pain. The mother may complain that she have the lower abdominal pain, and foul smiling lochia. Okay, the lochia means the after the delivery the discharge is known as lochia, so it may smell. Okay, so the smell will be, the odor will become very smelly. Okay, so that will be there. And tender uterus will be there. When you are performing the examination, abdominal examination, to find out the invulsion, there may be the tender uterus will be there, and subinvulsion will be present. Okay, more than the absence of invulsion, subinvulsion is the most common condition. Okay, so subinvulsion will be there, where there will be slow progress in the invulsion. Then obsessive vaginal discharge. Okay, the vaginal discharge will be present. Okay, so these are the signs and symptoms of what is that, perfural sepsis. Then management. The management include immediate management. Immediately you have to assess the condition of mother, that is check the airway, breathing and circulation, and maintain the IV infusion, and start with the IV administration with IV fluids, and blood antibiotic can be provided. Okay, in the form of IV, antibiotic should be administered, and antibiotics should be provided because of the high fever you can provide it. And painkiller also can be provided, because tender uterus will be there, tender abdominal will be there, so that should be provided. And uterine evacuation should be done if it is any kind of product is in the uterus or retained placenta, uterine evacuation should be done. And perineal care and hygiene should be provided, as well as nutritional support we have to provide to the mother. Okay, and monitor the vital signs, and maintain the input output chart. Okay, so these are the general management. And antibiotic include the injection of ampicillin and gentamicin. Okay, so that is the common drugs can be provided. And duration minimum 7 to 10 days it should be advised to take the mother for the medications. Okay, the nursing management include monitor the vital signs, that is especially temperature, because high elevation of body temperature is there, temperature should be monitored, pulse rate, what is that, respiration rate and blood pressure should be monitored, and assess the uterine tenderness and lochia. Okay, lochia should be examined. Okay, lochia should be checked out. Observe the lochia, that is vaginal discharge, and observe the sign of complication. Okay, any other complication is present or not, that should be checked out, and maintain the cleanliness, and asepsis should be followed for the mother care, and give the medications on time. Okay, and encourage the mother to take high amount of high intake of fluid. Okay, then provide the perineal hygiene, change the pads regularly, and monitor intake output chart. Okay, so that is the things you can provide as a nursing management. And regarding health education, you can explain the importance of hygiene, because uh, it is a sepsis infection, no? So you can explain about the importance of hygiene, and encourage the mother about the balanced diet. Okay, and advise yearly reporting of any danger signs. Okay, advise the mother regarding the danger signs. Okay, so this is the uh, one of the nursing management. Okay, along with the nursing education or the health education. Okay, so perfural sepsis means what? After the delivery, especially when the woman is having the high temperature with the infections. Okay, so that is known as perfural sepsis. Okay, the next one is breast encroachment. Okay, next one is we are going to discuss about breast encroachment. So the name itself is there, breast encroachment. What is the meaning of encroachment? Encroachment is the swelling and fullness and discomfort of the breast. Okay, due to the increased milk production. Okay, so it is the most common postnatal problem for the mother, especially for the preemie mother. Okay, so breast encroachment is the one of the most common problem. So what are the causes of this breast encroachment? Sudden increase in milk production. Okay, sudden increase in milk production is the one of the causes. And next one is infrequent or delayed feeding. Okay, so the mother is not feeding to the baby or the newborn. Okay, or infrequent feeding. Okay, infrequent feeding, because normally newborn should be feeded every 2 hours or 3 hours once. When it is infrequent feeding is happen, due to that the milk will be stored in the breast duct itself, so that may leads to the encroachment. Okay, so that may leads to the encroachment. The next one is poor attachment. Okay, or ineffective sucking. So poor attachment of latching. Okay, latching should be poor due to the like that may be the reason, or ineffective sucking. Okay, the baby is not able to suck properly the breast, so that may be the causes. The next one is long gap between the feeds. Okay, so as I told, 2 to 3 hours, every 2 to 3 hours the mother should feed the baby. When she is not feeding and 2 to 3 hours, that may leads to the condition. Okay, the next one is use of wearing the tight cloth. Okay, so that may be the reason. And next one is high salt diet. Okay, when the mother is taking the high level of salt, and that may be the reason for the breast encroachment. Okay, then signs and symptoms. So when you're talking about signs and symptoms, breast will feel full and heavy. The mother will complain that she have the uncomfortable. Okay, so heaviness in the breast. Okay, this will be there, and swelling will be there, and tight and shiny skin. Okay, the skin of the breast will be tight and it will be shining, and warmness and redness will be there, and pain and tenderness will be there, and it's hard to pump the blood, hard to pump the breast milk. Okay, and difficult in latching the baby. Okay, so when mother is putting the baby on the breastfeed, the baby will feel difficult to latch the breast, occur the nipple, or restlessness. The mother will complain that restlessness, and low grade fever. Okay, sometimes the mother may have the fever due to the encroachment. Okay, so this is the signs and symptoms. And risk factor, when you're talking about a risk factor, preemie mothers are the most common people who develop with breast encroachment. The next one is excessive milk production. The women who have secretion more amount of milk, no, so that may leads to the breast encroachment. Then cesarean delivery people, okay, cesarean section may be the risk factor. And next one is stress and fatigue. Okay, stress and fatigue also may be the reason to develop the breast encroachment. And next one is inexperienced mother. That's what preemie para mother we will tell. So that may be the risk factor to get the what is that breast encroachment. The next one is diagnosis. Okay, how to diagnose the condition based on the history only. Okay, based on the history of and symptoms. So the mother may complain that just heavy chest with the, or the what is that heaviness on the chest or chest area or the breast will be there, and based on symptoms, okay, tightness, as I told, no, tenderness and latching problems. Mother is baby is not feeding and the milk is not coming out because of the hardness. Okay, all these things will be collected as a history and complained as a things. Okay, the next one is physical examination of the breast. Okay, so breast examination should be done and rule of out of the mastitis or abscess, breast abscess or the mastitis. Okay, mastitis is the condition where the infection and inflammation occur in the breast. Breast abscess is the pus formation in the breast. That infection may leads to the pus formation. Okay, so all these conditions should be ruled out to find out the breast encroachment. Then management, when you're talking about management for this condition, frequent immediately relief means frequent breastfeeding is the one of the advice we have to provide, because when you are not feeding properly and delaying the feeding, it may lead to the breast encroachment. So frequent feeding should be provided. Correct latch, okay, correct position or latching should be done to the baby when the mother is putting the baby on the breastfeeding. Okay, and warm compression, warm compress before feed. Okay, so warm compress means you can apply the warmness, okay, so on the breast. Okay, so that can be not extreme cold or extreme cold, also heat also, warm application should be done, and cold compression after feed. Okay, so cold compression can be provided after the feed, and we advise the mother to wear loose supportive cloth, okay, for during the breastfeeding. That is the things. Okay, so that is the management we can take. And medical treatment, when we are talking about medical management, paracetamol can be administered as a to relieve the painkiller, because the mother is have the tenderness pain, so that can be provided. And antibiotic only if there is an infection. Okay, mastitis is there, then you can provide the antibiotic. Okay, then next one is adequate rest and fluid intake should be provided. So this all about the medical management. Prevention. So when you're talking about prevention, like short breastfeeding early. Okay, sorry. Uh, Start the breastfeeding early. So after immediately you can start the breastfeeding. You know, the normal breastfeeding can be initial feeding can be started immediately. If it is a vaginal delivery, within half an hour also we can start. Okay, so immediate breastfeeding should be advised to the mother to give the baby, and feed the baby frequently. Okay, so every 2 hours the mother can feed the baby to prevent the conditions, as well as ensure the proper latch on the breast. Okay, so baby is put correct position and latching should be done correctly. That should be make sure that, and avoid long gap between the feeds. Okay, so don't make the baby sleeping or baby is not demanding for the like feed like that. So avoid, don't make the gap between the first and second, or the feeding between the gap should be lesser, and wear proper supportive cloth, and balanced diet and adequate fluid should be taken. Avoid the stress and fatigue in the breast cells and breast abscess. Okay, so pus formation will be there, and decreased milk supply. Okay, decreased milk supply to the baby, so that may be the complication, and cracked nipples will be there. Okay, so due to not feeding, the nipples will get cracked, and maternal discomfort will be complication. Okay, so these are the early complication will occur when the mother is developed with breast encroachment. Okay, understood. Breast encroachment. The next one is the next condition we are going to discuss about postpartum blues. Okay, postpartum blues and postpartum depression. So these are the condition which will come under the like psychological complication in the postnatal time. Okay, so what is psychological complication means? The mother usually will have the psychological complication because she have undergone the intrapartum period more like more stress. Okay, so more stress will be there. So that is the thing will be leads to the postpartum psychological disturbance in the mother. So when you're talking about psychological complication, first one is postpartum depression, postpartum blues, and also like post psychosis. Postpartum psychosis is the last conditions. Okay, so what is first we'll discuss now postpartum blues. So what is postpartum blues means? A temporary emotional condition. Okay, it is a temporary emotional condition occurring in most mothers, okay, occurring to the most mother after the delivery. Okay, so emotionally the mother is disturbed, no, so that is the postpartum blues. Definition: a postpartum blue is a temporary mood disturbance that affect the mother in the first few hours or few days after the childbirth. Okay, after the childbirth, within few hours or within few days it may be affected with the mother. It is a common or mild, or it may be the life threatening condition. Okay, so mostly it is a common will be there, but it may be a mild condition also. When it's not identified and not provided the emotional support or not timely identified, it may leads to the life threatening. Okay, then incidence. What is the incidence of postpartum blue means? It occurs 50 to 50 percentage to 80 percentage of the new mothers, means first time mothers. Okay, so 50 to 80 percentage of preemie mother. Okay, preemie mother, it may be developed, and being on day of 2 to 3 days after the delivery. Okay, immediately within the second day or third day it may occur to the mother. Okay, usually disappear within 7 to 10 days. Okay, usually it will be disappear 7 to 10 days. If it is not, that may leads to the postpartum psychosis. Okay, that may leads to the postpartum psychosis. So what is the causes of this postpartum blues? Maybe sudden hormonal changes. Okay, so mother is having the hormonal changes, especially decreased estrogen and progesterone. That may the one of the reason to get the postpartum psychological disturbance and postpartum blues. Okay, the next one is physiological fatigue. Okay, physiological fatigue and lack of sleep. Okay, the mother is not having proper sleep, it may lead to the conditions. And emotionally stressed. Okay, emotionally stressed of the motherhood, worrying about the motherhood, how I am going to take care of the baby, or the mother is emotionally disturbed, that may be the reason to develop the condition. And pain, fever and anxiety. Okay, pain, fever, fear and anxiety. Okay, pain, fear and anxiety will be the reason. Then like separation from the family and the support. Okay, the mother is not having the support from family, may developed. Sometimes it may developed by the loss of baby also. Okay, so during the delivery, the mother is lost her baby, that may also reason for the developing the psychological problems. Okay, then risk factors. What are the risk factor means? First time mother who go are delivered the first time, that may be the risk factor to develop the postpartum blues. And next one is history of previous condition of psychological disturbance or psychosis or the depression or whatever things. Okay, then mood swings. Okay, so mother is having the mood disorders previously, that may leads to the things. And next one is lack of support. Okay, the mother is not getting the support from the people or family members, that may leads to the things. Next one is unwanted pregnancy. The mother is developed with the unwanted pregnancy. Okay, the mother don't want to continue her pregnancy, but now she delivered, so that kind of people also may be a risk to get the condition. The next one is financial and family stress. Okay, financial or family stress and lack of sleep or fatigue. Okay, so that is a risk factor of the condition. What are the signs and symptoms of postpartum blues, when you are discussing, mood swings will be there. Okay, the mother will have the mood swings, and irritability. The mother will be have the irritability, anxiety, oversensitivity. Okay, the mother will react immediately for anything also. If you are going and advising or anything, if you are talking also, she will react overly. Then difficult in concentration. Okay, difficult in concentration on the baby as well as the personal care, and feeling of over what is that we will tell, overwhelmed. Okay, so like she don't like the, she want to be withdraw from the society. Okay, so with social withdraw thought also may be present, and crime and poor appetite. Okay, so mother may not have the appetite, and restlessness. Okay, so these are the some of the signs and symptoms of these conditions. Okay, and management. So when you're talking about management, reassure the condition and listen to the mother. Okay, so what she want, that should be needed, and encourage to the mother regarding the rest and sleep, and help the mother with the infant care and the household work. Okay, the next one is encourage to express the feelings. Okay, advise the mother to express the feeling and provide the emotional support. Next one is encourage the balanced diet and fluid intake more, and involving the family and the partner. Okay, that also you can encourage, and usually subsides its own. Okay, it's so usually it will disappear for the within, as I told, 10 to 10, 7 to 10 days. If it is not, then you have to provide for the counseling. Okay, the nursing care include assess the mood and emotional state of the mother, and provide a calm and supportive environment, encourage the visualization of feelings, like open up. Okay, then promote the rest and teach the relaxation therapy or the techniques. Okay, you can advise the mother regarding the relaxation techniques, that is deep breathing and slight musical therapy can be provided, and educate the family about the conditions. Okay, so that is because emotional support is very very important, so you can advise the mother about the or family about the support, and monitor for the sign for depression. Okay, whether the mother is going depression or not, that should be monitored. Okay, so this all about the nursing care about the postpartum blues. The next condition we are going to discuss about postpartum depression. Okay, postpartum depression. So what is postpartum depression? Again, it's one of the common in postnatal mother, especially again preemie mother, a mood disorder that occurs in the first 2 3 days or first week. Okay, within the week during the postpartum period. Okay, usually within 4 weeks it will be disappear. Okay, so that is the thing. So what is the definition of this condition? Perfural depression or postpartum depression is a non-psychotic disorders. Okay, non-psychotic disorder or depression that occurs after childbirth. Okay, that occurs after the childbirth, and usually being within the first 4 weeks. Okay, so usually it will be seen in within 4 weeks of postnatal time, but may occur anytime at the from the first year. Okay, in the 1 year of postnatal time, it may occur anytime. So that is known as postpartum depression. Okay, again, causes and risk factor, hormonal changes is the one of the causes or the risk factor, that is in decreased estrogen and progesterone hormones, and physical exertions. Okay, so mother is physically exertion means because the mother, again the breast changes will be there, no, the mother have to feed the baby, all these things will be leads to the condition, and stress and anxiety. Okay, so the mother having stress and anxiety may leads to the postpartum depression, and previous history of depression. Okay, the mother during antenatal or during her adulthood, she developed with some kind of depression that may appear in the postnatal time. Okay, then lack of social support. Okay, again lack of family support or social support, and unplanned pregnancy. The mother is not planned for pregnancy and she is now become pregnant and got a baby also. So due to that, there may be a risk for the condition, and complication during pregnancy or delivery. Okay, any complication is arised in during pregnancy or the delivery time, that may leads to the depressional conditions. Okay, then financial problems, poor relationship with the partner. So all these things, the risk factor for are the causes for the postpartum depressions. Okay, postpartum depression. And signs and symptoms. What are the signs and symptoms means? Emotionally, when you're talking about mother, the mother will have sadness. Okay, so always the mother will have sad and crying and irritability. The mother will have the irritability, anxiety, feeling of guilt, and loss of interest with this baby as well as the personal care or whatever things, and worthlessness. Okay, so she will think that why I'm there like that and all. So that is the thing. And physically, when you're talking about, the mother will have weakness, fatigue, loss of appetite, and headache, body ache. Okay, by back pain or body pain or sleep disturbance will be present. Okay, and then behaviorally, when you're talking about behaviorally, the signs and symptoms include social withdrawal. Okay, see, we don't want to mingle with anyone. Okay, she will be withdraw from family as well as the friends, and difficulty to give the care for the baby or the newborn. Okay, she won't provide any care to the baby also. So that will be the signs and symptoms. And diagnosis. When you're talking about diagnosis, based on the history and the clinical assessment, we have to diagnose the mother that she is having the depression. Okay, so based on the symptoms, it will be there. Screening, what are the screening test can be done means, that is some postnatal depression scale. Okay, using the depressional scale, we can identify the things and rule out the other medical and psychiatric conditions. Okay, all these things will become under the diagnosis. And management, when you're talking about management, non-pharmacological management include reassurance the condition and emotional, provide the emotional support to the mother, and counseling and psychotherapy provided. Okay, you should provide the counseling and psychotherapy can be provided. And cognitive behavioral therapy is one of the important non-pharmacological treatments, so you got to provide. And involving the family and the partner more in the care. Okay, so making the family members, making the husband to talk to the mother and providing care, that is very important. And the next one is encouraging the breastfeeding. Okay, so make the mother to motivate the mother to provide the breastfeed to the newborn. And stress management techniques. Okay, so that is relaxation, meditation, yoga and all can be advised to the mother. So when you're talking about pharmacological management, that is antidepressant drugs. Okay, antidepressant drugs can be administered as per the doctor order or physician order. Okay, treat only with the mother is not having under the medical supervision. Okay, so that is very important. Okay, then nursing management include build the rapport between the patient and the nurse, as well as make the trust. Okay, so when you are making trust, rapid, that may make the mother to tell about her problems openly, so that trust building should be happen to the nurse between the patient. And listen to the mother patiently. Okay, so first listen to the mother about her complaints and provide emotional support, encourage the expression of feelings, allow the mother to express her feelings, and involve the family members in the care. Okay, then ensure the adequate rest and sleep. Okay, so you can make sure that the mother should have the proper rest and sleep, and promote the nutrition and hydrogen, and help in baby care. Okay, we have to provide the help in provide the newborn care, and observe the mother for any kind of suicidal thought is there or not. Okay, then observe and continue monitoring is very important. And if it is there, refer the psychiatrist if it is needed. If the mother is needed for the counseling, you can refer the mother to the psychiatrist. Okay. So this all about the things. And when you're talking about the complication, poor mother infant bond will be there, neglect of baby will be there. Okay, family relationship problem will be developed. chronic depression. When you are living this condition, the mother may leads to the depressive conditions, okay, and suicidal thought and attempts also may be performed to the mother, okay. So I hope you understood these 5 topics, correct? So that is the PPH, perfural sepsis, and breast encroachment, postpartum blues, and postpartum depressions, okay. So this is the most common topics when we are talking about the postnatal complication. So what is the difference between this postnatal depression and postnatal blues when you are talking? It starts, postpartum blues will start within 2 to 3 days after the delivery, and it may start any time within 1 year also, okay. The depression may start with any time after the things within 4 weeks, after the 4 weeks, or it may be within 1 year also the depression may be developed. And postpartum blue have the mild symptoms, whereas the postpartum depression will have the severe symptoms, okay. Then it may be disappear within 7 to 10 days, but it will be present in long duration, okay. Depression will be present in the long duration. This postpartum blues does not involve does not interfere any normal life, day-to-day life, okay. But this depression will be involving, or it will be suppress the normal day-to-day life, okay. So that is the thing. And here no need for drugs, but here antipsychotic drugs is administration is very important, okay. So that is the differentiate between the postpartum blues and postpartum depression, okay. Thank you.
Hello everyone, welcome back to Nursing Guru YouTube channel. This is the class today regarding OBG in the recognition and management of the problems during the pregnancy. Which are all the problems occurring during the pregnancy? We are going to manage and give the treatment in this chapter. We are going to study regarding it. In that, first we are going to study regarding how we are going to assess the problems. Assessment of the high risk pregnancy. High risk pregnancy means what? The high risk pregnancy, it is the pregnancy in which the mother, fetus or the both having increased chance to developing health problems before, during and the after the delivery. It requires close monitoring and the specialized care. The assessment of the high risk pregnancy. High risk pregnancy means it is the pregnancy here the fetus or the mother and also the both can have the chance to get the problems at the time of before the pregnancy, during the pregnancy. We are going to manage that. We will call it as assessment of the high risk pregnancy. Next is the components of high risk pregnancy by using which are all the methods we are going to assess the high risk pregnancy. In that, first one, history taking, next physical examination, obstetrical examination, laboratory investigation, fetal assessment, and the high risk identification, high risk factor which is going to affect the health of the both mother and the fetus. These are all the components to assess the high risk pregnancy. First one, history takings, physical examination, obstetrical examination, laboratory investigation, fetal assessment, and the risk factor identification. In that, problems or the complications of the pregnancy, it means same thing here, the pregnancy complication, the mother or the fetus and also the both can having the problems at the time of or during or at the time of pregnancy, that we will call it as complication or problems of the pregnancy. Pregnancy complication are the health problems that affect the mother, fetus or the both during the pregnancy. They may occur before, during or after the childbirth and requires the immediate diagnosis and the management. In that, first we are going to study the disease condition or the complication at the time of pregnancy, that is hyperemesis gravidarum. Hyper means excessive, emesis means vomiting. The excessive level of the vomiting at the time of pregnancy, that we will call it as hyperemesis gravidarum. The definition is hyperemesis gravidarum. It is a severe form of nausea and vomiting during the pregnancy that leads to the dehydration, electrolyte imbalance at the and also the weight loss, that we will call it as the definition of hyperemesis gravidarum. Hyperemesis gravidarum, it is a condition in which there will be a excessive level of the vomiting and the nausea. Due to this, there will be a dehydration, electrolyte imbalance and also the weight loss. The causes for this, increased level of pregnancy hormones, it may be human chorionic gonadotropin and also the estrogen level. If the estrogen level and the human chorionic gonadotropin hormone if get increase at the time of pregnancy, the severe vomiting may occur, and multiple pregnancy and previous history of hyperemesis gravidarum and also if it is the first pregnancy, it may occur. Then psychological and genetic factor, due to the genetics also it may be occur. These are all the main causes for the hyperemesis gravidarum. Next is how, due to the hyperemesis gravidarum, what are all the signs and symptoms may occur to the mother. First thing, there will be a severe nausea and the vomiting and inability to retain the food or the fluids. There will be a weight loss. It may be more than 5% of the normal weight of the mother. Then dehydration will be there due to excessive nausea and vomiting, dehydration in the body, dry mouth, thirst, decreased urine output and also dizziness and the weakness, electrolyte imbalance may occur, and tachycardia due to the hyperemesis gravidarum, increased heart rate may occur, and also hypotension, decreased blood pressure. These are all the signs and symptoms due to hyperemesis gravidarum. Next is diagnosis. How we are going to diagnose the hyperemesis gravidarum? Due to by using the history collection and the physical examination, urine test for the ketones and also the blood test. In the blood test, we are going to do the complete blood count and also the electrolytes, and also we are going to do the liver and the kidney function test, ultrasound to find out the multiple pregnancy. Next, how we are going to manage the hyperemesis gravidarum? Medically, we are going to manage through the IV fluids. Main thing is IV fluids to correct the dehydration and also the balance the electrolytes in the body, and also electrolyte replacement, antiemetic medications, example ondansetron. Then vitamin supplements and nutrition supplements to recreate the oral. It may be the nutritional support for to recreate the body hydration or recreate the body dehydration and also the nutrition in the body. These are all regarding the medical management for the hyperemesis gravidarum. Then also the nursing management includes monitoring the vital signs, assess the intake and output chart, monitoring the body weight daily, administration of the IV fluids and medication as per prescribed medication. Then encourage the small and frequent meals after the vomiting. Vomiting decreases, avoid the food and odors. which is going to trigger the nausea. We are going to avoid the foods and also to provide the oral hygiene, offer the emotional support and reassurance, and monitoring the fetal well-being. Next is, this is all regarding the hyperemesis gravidarum. The hyperemesis gravidarum, it is a condition in which there will be a excessive nausea and vomiting. Due to this, there will be a dehydration in the mother. Next condition is bleeding in early pregnancy. If vaginal bleeding in the early pregnancy, it may occur. There are the several conditions. In that, first one, abortion. Abortion, it is a termination or loss of the pregnancy before 20 weeks or after the before 20 weeks of gestation, or before the fetus going to birth, or fetus going to get the 500 gram of the weight. This is, we will call it as abortion. The types, first one is threatened abortion, intable abortion, incomplete abortion, complete abortion, missed abortion, septic abortion, and recurrent abortion. Threatened abortion means vaginal bleeding will be there, but the cervix is going to get closed and pregnancy may be continue. Then inevitable abortion means bleeding will be there with the open cervix. The abortion, we are not able to control the pregnancy here. The abortion cannot be preventable. This cannot be preventable. Then incomplete means some products of the conception are expelled while some remaining in the uterus. The complete abortion means all the products of conceptions will be expelled from the uterus. Then missed abortion means fetal death occur but the products of conception remains in the uterus. Then septic abortion means due to the infection there will be abortion. And recurrent abortion means three or more abortion may occur for the spontaneously. These are the types of the abortion. Next is ectopic pregnancy. Ectopic pregnancy, it is a pregnancy in which fertilized ovum implants outside the uterine cavity, most commonly in the fertilization. After this will enter to the, in the normal condition, this fertilized ovum will enter to the uterus and it will get implant in the uterine walls. That is normal condition. If this fertilized ovum got implanted in the fallopian tube or other than the uterus, that we will call it as ectopic pregnancy. Ectopic pregnancy is a pregnancy in which the fertilized ovum implants outside the uterine cavity. Other than the uterine cavity, it is going to get implant, that we will call it as ectopic pregnancy. Most probably it is going to implant in the fallopian tube in the ectopic pregnancy. Then for this, the common sites includes fallopian tube. It may be 95 to 98%. There is a chance to get the ectopic pregnancy in the fallopian tube, and also in the ovary and the cervix and abdominal cavity, and also the previous cesarean mark where the scar will be present. There may also get the implantation of the fertilized ovum. This we will call it as ectopic pregnancy. Ectopic pregnancy, it is a condition in which the fertilized ovum is going to get implant other than the uterine cavity, most probably fallopian tube. Next, vesicular mole. Vesicular mole or hydratiform mole means this is a type of gestational trophoblastic disease in which the placental tissue grow abnormally. The placental tissue are going to grow abnormally, forming a grape-like a fluid-like structure. Forming a grape-like fluid filled vesicles inside the normal placenta. Inside the normal placenta, there will be abnormal formation of the tissue. It may be filled with the fluid and grapes like a structure, that we will call it as vesicular moles. In this also types are there, complete mole and the partial mole. Complete mole means no fetus will be present in the uterine cavity, and also placenta is completely abnormal. The placenta will be completely abnormal, that is complete mole. Then partial mole, an abnormal fetus or the fetal tissue may be present and only the part of placenta is abnormal. In the complete, the fetus will not be present in the uterus, and also the placenta is completely abnormal, it is. Then partial means the fetus, some part of an abnormal fetus or fetal part will be present in the uterine cavity, and also the part of the, some part of the, only the part of the placenta will be abnormal. This is the two types of vesicular mole. Vesicular moles means it is a condition in which there will be a placental tissue abnormalities like a fluid like structure, or the grape like a fluid filled vesicles will be present in the placenta. In that two types, complete mole and the partial mole. Complete mole means there no fetus will be present in the uterine cavity, and also the placenta is completely abnormal. Partial means abnormal fetus part will be present in the uterine cavity, and also the only the some part of the placenta is going to get abnormal. This is two types. Next, how we are going to manage this vesicular mole means assess the maternal condition and the stabilize if it is necessary, and also IV fluids or blood transfusion if the bleeding is more. Then medication as per prescribed. Then surgical treatment when indicated. Example, evacuation of retained products, and also surgery for ectopic pregnancy. If the surgery for ectopic pregnancy, we are going to give the surgical treatment, and also anti-D immunoglobulins for Rh negative mother when it is indicated. If it is indicated, we are going to give anti-D immunoglobulins. This is regarding bleeding in the time of pregnancy. Bleeding in the time of pregnancy, they include abortion, vesicular mole, abortion, and ectopic pregnancy. Next condition is placental previa. Placental previa is a condition in which the placenta is implanted in the lower uterine segment. It may be partial or completely. Here the placenta is going to get grow. It may be lower uterine segment, implanted in the lower uterine segment. It may be partial or complete covering of the internal cervical opening or internal OS. Internal organs is going to covered by this placenta. The placental previa, it is a condition in which the placenta is going to get grow in the lower segmental or implanted in the lower segmental of the uterine cavity. It may be partially or completely going to completely cover the OS, internal OS of the parts of the female reproductive system, that we will call it as placental previa. Then the types is there: complete placental previa, partial placental previa, marginal placental previa, and low lining placental previa. Complete means the placenta completely covers the internal organs. If it is if the placenta is going to develop here and completely internal organs are going to get covered, that is complete. Partial, the placenta partially covers the internal organs. If it is going to get implant in the partially part of the cervix or the internal organs will be covered partially. Marginal also, it is going to the implant, the placenta is going to implant at the margin layer of the cervix. Then lower lining placenta, it is going to completely line or implant in the lower part of the female reproductive system. This is regarding placental previa. Placental previa, it is a condition in which the placenta is going to implant in the lower segmental of the uterine segment. In this, there are the four types: complete, partial, marginal, and the lower lining. Next, the signs and symptoms regarding the placental previa includes sudden, painless, and the bright red color vaginal bleeding will be there. Bleeding usually occurs after the 20 weeks of the pregnancy, and non-tender uterus will be there, and normal fetal heart rate unless bleeding is severe. Then malpresentation, it may be breech or transfer line may be present. Then diagnosis, we are going to do the history collection, physical examination, and also the ultrasound scan to assess the lie of or malpresentation of the fetus, and also complete blood test or blood count, and also group and RH typing, fetal heart rate monitoring. This is regarding the diagnosis and the signs and symptoms of placental previa. Then how we are going to manage the placental previa includes in that first one hospital observation if the bleeding is mild and bed rest as advised, monitor the maternal vital signs, monitor the fetal well-being. Then if the preterm delivery is likely, we are going to do the blood transfusion if it is needed and corticosteroid if it is a preterm labor or preterm delivery. Then active management, emergency cesarean section we are going to do if the bleeding is severe. Then vaginal delivery may be possible in selected cases, lower lying or marginal placenta. The types of placental previa I said no, in that marginal or lower lying placental previa, if it is there we can do the vaginal delivery. If it is not there means emergency cesarean section we are going to do. This is the management regarding placental previa. Next is abruptio placenta. Abruptio placenta, it is a premature suppression of the normal implantation of the implanted placenta from the uterine walls after the 20 weeks, after the 20 weeks of the pregnancy or before the birth of the baby. If the placenta got implanted placenta got detached or placenta from the suppression or detached from the uterine walls, that we will call it as abruptio placenta. Abruptio placenta, it is a condition if the placenta, implanted placenta detach or separate from the uterine wall before the 20 weeks of the pregnancy or before the birth of the baby. It is an obstetrical emergency condition and we are going to manage here. Here the types includes concealed abruption or the blood remains trapped behind the placenta with a little or no visible vaginal bleeding. Without vaginal bleeding, if it may be present little bit or no vaginal bleeding, but the blood will be trapped behind the placenta. Then relieved abruption means external abruption. Here the blood escape through the vagina. Then mixed abruption, the both may be there. One it may be bleed may occur or it is going to trap behind the placenta, that is mixed abruption. The abruptio placenta, it is a condition in which the placenta, implanted placenta, it is going to separate it from the uterine wall before the 20 weeks of the pregnancy or before the delivery of the baby. Next is the signs and symptoms of this condition. Sudden and painful vaginal bleeding will be there. Severe abdominal or back pain will be there. Tender and hard uterus. Frequent uterine contraction. Reduced or absent fetal movement. Signs of shock may be present. Fetal distress or absent fetal heart rate sound may occur. These are all the symptoms of abruptio placenta. We are going to diagnose through the history collection and the physical examination and also the ultrasound scanning and fetal heart rate to assess the fetal well-being and complete blood count, and also the group of the blood group we are going to identify to check main thing RH typing. Next, we are going to manage in the medical management. We are going to first admit the mother to the hospital immediately and stabilizing the mother by giving the IV fluids. Then blood transfusion if it is required. Continuous fetal monitoring should be there. Fetal heart rate and the fetal movements we are going to continuously monitoring, and also correct the coagulation abnormality if it is present, and promote the delivery. It may be vaginal or cesarean delivery we are going to do. This is regarding medical management of abruptio placenta. And nursing management, as we have studied previous, monitor the maternal signs, vital signs, and assess the amount of the vaginal bleeding. Observe the signs of the shock and heart rate, monitoring the fetal heart rate, and IV fluids. We have given the IV fluids to stabilize the mother. We are going to maintain and monitoring the IV fluids. Then preparing the patient or the mother for the emergency delivery if it is required. Emotional support for the mother. This is all regarding the management of abruptio placenta. Abruptio placenta is a condition in which the implanted placenta is going to separate from the uterine wall before the 20 weeks of the pregnancy or before the delivery of the baby. Next condition is anemia in pregnancy. Anemia is a condition in which the hemoglobin level is less than 11 gram per dl during the pregnancy time. If the hemoglobin level is less than the 11 g per dl at the time of pregnancy, that we will call it as anemia. It resulting in the reduction of oxygen carrying capacity of the blood. It is one of the most common medical disorder in that at the time of pregnancy. Then types also there for the anemia. Iron deficiency anemia, it is the most common, and folate deficiency anemia, vitamin B12 deficiency, hemolytic complete blood less or complete blood will be reduced in the body, and aplastic anemia and sickle cell anemia. Here the red blood cells will be at the moon, that we will call it as sickle cell anemia. These are all the types of anemia. The anemia is a condition which is present at the time of pregnancy. There will be a low hemoglobin in the body of the mother. Next, we are going to manage the anemia. In that, medical management includes iron and folic acid supplements, oral iron therapy for mild to moderate anemia, intravenous iron for the women who cannot tolerate or do not respond for the oral iron, and blood transfusion if it is a severe anemia. Then treat the underlying causes like drowning, nutritional deficiency. Then nursing management, monitoring the hemoglobin level, encouraging like green leafy vegetables and beans, meat, egg, and advise to take the iron tablet for the mother, and teach to the woman to avoid the taking iron tablets with the tea and coffee, and monitor for side effects of iron therapy, and educate the mother about the importance of the regular antenatal checkups or regular antenatal monitoring. This is a management regarding anemia. Anemia is a condition. There will be a less hemoglobin level at the time of pregnancy. In that, types are there. For six main types: iron deficiency anemia, folate deficiency, vitamin B12 deficiency, hemolytic anemia, aplastic anemia, and sickle cell anemia. This is regarding management. Next, here we are going to study the preeclampsia and the eclampsia. What is the difference we are going to study, and also the disease condition or the problems. First one is preeclampsia. Preeclampsia means the high blood pressure that develops after the 20 weeks of the pregnancy with the proteinuria. There will be a high level of protein in the urine, and signs of organ dysfunction, that we will call it as preeclampsia. It is a condition in which there will be a high blood pressure. It may be present, it will be present or develops after the 20 weeks of pregnancy with the proteinuria. It also indicates the signs of dysfunction or signs of organ dysfunction, that is preeclampsia. Eclampsia means there will be a severe complication of preeclampsia. It is going to occur at the time before the pregnancy. Eclampsia, severe complication of the preeclampsia, in which the woman develops generalized seizure or convulsion. Convulsion or the seizure will develop in the eclampsia. Here also high blood pressure will be there. Is a severe complication of preeclampsia. Preeclampsia is a condition in blood pressure at the time of before the pregnancy. Sorry, after the 20 weeks of pregnancy with the proteinuria, and also or the signs of the organ dysfunction, that is preeclampsia. Eclampsia is a severe complication of the preeclampsia. Here there will be a generalized, or it is going to develop the general seizure or seizure in the preeclampsia. Seizure will be present in the eclampsia. Then blood pressure will be more than 140 by 90 mmHg, and the blood pressure in the eclampsia will be more than or equal to 140 by 90. Then symptoms indicates the headache will be there, blurred vision, swelling, epigastric pain, and the proteinuria will be present here. And here the symptoms in the eclampsia includes all features of preeclampsia plus seizure or convulsion, loss of consciousness, or it may convert into coma. This is regarding preeclampsia and eclampsia. Preeclampsia is a condition in which there will be a high blood pressure after the 20 weeks of the pregnancy, and it is with the proteinuria, excessive level of the protein in the urine, and also is going to signs or indication to the dysfunction of the organs, and seizure will be absent here, and and symptoms like headache, blood vision, swelling, and epigastric pain, and also proteinuria. This is regarding preeclampsia. Eclampsia means severe complication of the preeclampsia. Here it is going to develop the generalized seizure, and seizure will be present here, and the blood pressure will be more than or equal to 140 140 by 90 mmHg with the convulsion, and symptoms like, main thing here there will be a seizure and also loss of consciousness, and also it may convert into coma. This is regarding preeclampsia and eclampsia. Next is gestational diabetes mellitus. Gestational diabetes mellitus is a condition in which there will be a high glucose in the blood at the time of pregnancy. Gestational diabetes mellitus in glucose tolerance, the high blood sugar or the blood glucose that is the first diagnosed during the pregnancy, usually after 24 to 20 weeks of the gestation. At the time of or after the 24 to 28 weeks of the gestation, there will be a high blood glucose in the body of the mother, that we will call it as gestational diabetes mellitus. The symptoms includes, some of the mother or the woman will not be having any symptoms, or if the symptoms occur, it may be increased thirst will be there, frequent urination, increased hunger, fatigue, and recurrent UTI or urinary tract infection may occur due to gestational diabetes mellitus. Gestational diabetes mellitus is a condition in which there will be excessive or high blood glucose level in the time of pregnancy. It may occur after the 24 to 28 weeks of the gestation. The symptoms, some women will not be having any symptoms. If it is there, means it indicates increased thirst, frequent urination, increased hunger, fatigue, and the recurrent urinary tract infection. Now, how we are going to diagnose the gestational diabetes mellitus? They includes oral glucose tolerance test at the time of 24 to 28 weeks of the pregnancy, and blood glucose monitoring, urine test for the glucose screening, for only for screening. Then management, diet modification, regular physical activity, blood glucose monitoring by using any method, and insulin therapy if the blood sugar is not controlled with the diet and exercise. Regular antenatal checkup. This is regarding management and the diagnosis of gestational diabetes mellitus. Next condition is cardiac disease in the pregnancy. The cardiac disease in the pregnancy refers to any heart disease that is present before pregnancy or develops during the pregnancy. It affecting the mother cardiovascular function and increasing the risk of complication for the both mother and the fetus. Cardiac disease in the pregnancy, it is a condition. It refers to the heart disease, any heart disease that occurs at the time of pregnancy. It may affecting for the both mother and the fetus, and the main thing here, it is going to affect the mother's cardiovascular function. The types of cardiac disease in the pregnancy includes congenital heart disease, rheumatic heart disease, valvular heart disease, and cardiomyopathy, arrhythmias, and last one is ischemic heart disease. These are the types of cardiac disease in the pregnancy. Next, the signs and symptoms of cardiac disease in the pregnancy: shortness of breath, fatigue, palpitation, the mother is feeling her heartbeat itself, and chest pain will be there, swelling of the feet and the ankles, and persistent cough will be there, cyanosis or bluish discoloration of the skin, and the syncope will be present. Then how we are going to diagnose the condition means, or the heart disease means, history collection and the physical examination, and also the blood pressure and the pulse monitoring or vital signs monitoring, ECG, electrocardiogram, then echocardiogram, chest x-ray, blood test, and fetal heart sound or fetal ultrasound we are going to do. Then management, regular antenatal follow-up with the obstetrical and cardiologist, medication as prescribed, oxygen therapy if required, treatment of heart failure if present, and planned delivery in a well-equipped hospital. This is regarding the diagnosis and management. And the heart diseases may be present. These are the types of heart disease which present in the time of pregnancy. Then sexually transmitted disease in the time of pregnancy. The sexually transmitted disease are the infectious that are mainly spread through the sexual contact, including vagina, anal or oral sex. Some sexually transmitted disease can be transmitted from the mother to baby during the pregnancy, childbirth, and also the breastfeeding. The sexually transmitted disease or the which occurs at the time of pregnancy due to infections, infectious disease, it may transfer from the mother to the baby through the pregnancy, childbirth, and also the breastfeeding. The commonly sexually transmitted disease includes HIV, human immunodeficiency virus infection, then syphilis, gonorrhea, chlamydia, genital herpes, genital wasp, then trichomoniasis, then hepatitis B. Next, the signs and symptoms of sexually transmitted disease includes abnormal vaginal or perineal discharge will be there, pain or blood burning during the urination, genital sores or ulcers, and itching around the genital area, lower abdominal pain will be there, pain during the sexual intercourse, and fever will be present. Some people may having no symptoms. The diagnosis, medical history or history taking and physical examination, and also blood test, urine test, swab test for the from the genital area, and rapid test for the HIV and syphilis. We are going to manage through the medications like antibiotic for bacterial sexually transmitted disease, antiviral medicine for viral sexually transmitted disease, antifungal or antiprotozoal medicine with indicated, if it is indicated, we are going to give the antifungal and antiprotozoal. Treat the sexual partners to prevent the reinfection and also regular follow-up. Next is urinary tract infection in the time of pregnancy. Urinary tract infection is an infection of any part of the urinary system. It may be occur to the kidney, uterus, bladder or the urethra. It is a common disease or the common infection during the pregnancy due to hormonal changes and the pressure from the growing uterus. The urinary tract infection, it is a infection which occurs in the time of pregnancy, and it is one of the common infection which occurs at the time of pregnancy due to hormonal changes. It may be hormonal changes or the pressure from the growing fetus. The types of urinary tract infection includes asymptomatic bacterial or bacterial infection without a symptoms, cystitis, the infection of the bladder, and the Pyelonephritis, infection of the kidney. It is a more severe condition in the UTI. Next is the signs and symptoms of the urinary tract infection includes burning sensation at the time of urination, frequent urination will be there, urgency to urination, and lower abdominal pain will be there, and the cloudy or foam smelling will be there with the urine. And diagnosis, urine routine examination, urine culture and the sensitivity, complete blood count and kidney function tests if it is required. Then management for this, medical management for the bacterial infection, antibiotic we are going to give, adequate fluid intake, and paracetamol for the fever if it is needed, and hospitalization and IV antibiotics we are going to give. The nursing management includes monitoring the vital signs, encouraging to increase the oral fluid intake for the patient, and monitoring the urine output, administer the prescribed antibiotics, then teach the proper perineal hygiene for the woman, and encouraging the complete emptying of the bladder and monitoring for the signs of infection. Then next condition is appendicitis. It is one of the surgical management condition. Appendicitis in the pregnancy, it is an inflammation of the appendix. Appendicitis is a condition in which there will be a infection and inflammation of the appendix in the time of pregnancy, that we will call it as appendicitis. The main causes for this includes the obstruction of the appendix by the fecal matters, then swollen lymph node tissue, rarely parasites or tumor may occur. Next, the signs and symptoms includes the nausea and vomiting will be there, right-sided abdominal pain, the main symptom of the appendicitis, nausea, vomiting, loss of appetite, mild fever will be there due to infection, and tenderness of over affected area. The affected area will be get dark color or tenderness. This is the signs and symptoms and the causes of the appendicitis. Next, the diagnosis of appendicitis, history taking and physical examination, blood test, white blood test, white blood count we are going to do here, and urine examination, ultrasound to assess the fetal imaging test or fetal heart rate or fetal position we are going to assess, and MRI test and CT scan. Treatment, hospital admission, first immediate hospital admission, and nil by oral and intravenous fluids, antibiotics to control the infection, and appendectomy. The surgery we are going to do the appendectomy. Appendectomy, it is a surgical removal of the appendix if it is not treated by the medication. Next condition is hydramnios. Hydramnios, it is also called as polyhydramnia. Polyhydramnia, it is a condition in which there will be an excessive level of amniotic fluid which present in the uterine walls, that we will call it as hydramnios or polyhydramnios. The polyhydramnios is a condition in which there is an excessive amount of the amniotic fluid surrounding the fetus during the time of pregnancy. The causes includes the maternal cause and the fetal cause. The maternal cause includes gestational diabetes mellitus and the RH incompatibility. RH incompatibility, if the mother having the negative RH negative blood group, the fetus will be having RH positive blood group. Next, for the fetal causes includes congenital abnormalities may be present, or if the mother having multiple or the multiple pregnancy may occur. It may be causes for the hydramniosis and fetal anemia and also fetal infection. Next, the signs and symptoms of this, the rapid increased abdominal size will be increased, and breathlessness, abdominal size will be increased, and breathlessness, abdominal discomfort, and swelling of the legs, difficulty feeling fetal parts, difficulty to feel the fetal parts, and excessive fetal movements will be present due to polyhydramniosis. Then we are going to diagnose through the history collection and physical examination, ultrasound, and amniotic fluid index we are going to assess. Amniotic fluid index, it should be the normal, the index will be more than 24 centimeter, and maternal blood sugar testing and fetal amniotic scan we are going to do. This is all regarding diagnosis. Next, the treatment for this polyhydramniosis includes treat the underlying causes, regular antenatal monitoring, medications such as indomethacin may be used to selected cases under the specialist supervision or prescribed, and therapeutic amniotic reduction we are going to do, and timely delivery when it is indicated. Next condition is intrauterine fetal death. Name only indicates that intrauterine, inside the uterus or inside the uterine walls, the fetus is going to got death. We will call it as intrauterine fetal death. Is a death of the fetus inside the uterus after the 20 weeks of the pregnancy and before the death. We will call it as intrauterine fetal death. Then next condition is elderly primigravida. Elderly, more than 35 years women going to get the pregnancy for the first time, that we will call it as elderly primigravida. And elderly primigravida is a woman who is going to pregnant for the first time at the age of 35 years or older at the expected date of delivery. Next condition is management and care of high risk pregnancy condition as per Government of India. Before this, these are all the disease conditions, these are all the problems at the time of pregnancy. Next is as per the government protocols, we are going to manage the high risk pregnancy. They includes the Government of India through the Ministry of Health and Family Welfare and also the National Health Mission recommends the following principles to care or management of the high risk pregnancy. They includes early identification, regular antenatal care, medical management, nutrition and supplements, fetal survivals and referral and emergency care, delivery care and the postnatal care. These are the 8 main principles which is given by the Government of India. These are the protocols to manage and the care of the high risk pregnancy. They includes early identification, regular antenatal care, medical management, nutrition and supplements, fetal surveillance, referral and emergency care, delivery care and the postnatal care. Then next is the drugs which we are going to use to maintain or manage the high risk pregnancy to control the anemia. The conditions are here. The anemia condition, we are going to give the drug that is ferrous sulfate plus folic acid. The purpose is to treat the anemia. Then preeclampsia, for that we are going to give the drug that is labetalol and nifedipine to control the blood pressure. Eclampsia, magnesium sulfate to prevent and treat the seizure. Then gestational diabetes mellitus, we are going to give the insulin to treat the or control the blood glucose level. And preterm labor, nifedipine we are going to give to delay the labor. Preterm means before the gestation week, the labor or the delivery is going to happen. To control that, to delay the labor, we are going to give the drug. Then hyperemesis gravidarum, ondansetron, I already informed this one. Ondansetron to control the nausea and vomiting, Then urinary tract infection, amoxicillin and cephalexin to treat the infection. Postpartum hemorrhage, oxytocin to prevent and control the bleeding. These are all the drugs which we are going to give to control and management of the high risk pregnancy. This is all regarding the management of the pregnancy during the time of pregnancy. Management and care of the pregnancy or the problems for the at the time of pregnancy. In this, the main importantly, they have asked the appendicitis and the drugs and also the protocols which is given by the Government of India. The protocols which is given by the Government of India, and these are all the drugs which is used to maintain the high risk pregnancy. I hope you all understand the topic and the unit. If you have any doubt, you can comment it down. Thank you for watching.